All right, guys, it's 8:30. I say we get started with this conference. Can everyone hear me? Awesome. So welcome, everyone. My name's Dr. Adamakis. I'm the Associate Program Director of the Metropolitan Harlem Emergency Medicine Residency. As well, I'm the Chair of Fundraising for the Gender Equity Medicine Research Foundation, which is part of FemINM, and I'm also one of the ALL NYC faculty members, and I will be hosting this conference today. So a couple housekeeping points before we get started. Everyone, please make sure your microphones are on mute. Please have your names up. You could also include your institutions. So Bo Guan, you are not muted. I'll fix that. You can put your names, your institutions. It's nice to know where people are coming from. Make sure you're muted, and we hope you enjoy this conference. You are going to see a QR code on your screen. That's for us to take attendance and for registration. Please just scan it with your phone. If you have an iPhone, you can use a camera and it will capture and go directly to the link. Or if you don't have an iPhone, you can use a QR phone application reader. So without further ado, let's get started. Welcome. Make sure you use the QR code and register. Also, we're going to be on share screen mode most of the time. One of the best things would be if maybe half of your screen, you can see the slides, and then the other half of the screen, you actually see the videos, because we're going to have different lecturers come up, different panel members come up. So it'd be nice if you get to see everyone who's going to be talking. So as I said, I'm the Associate Program Director of the used to be Metropolitan Hospital Emergency Medicine Residency. We've recently joined with Harlem, and we're now called the Met Harlem Residency. As well as taking care of your usual types of patients that we normally see, we're also getting our residents exposed to a lot more trauma. We have a very rigorous didactic curriculum. We also have our residents presenting at national conferences, lectures, research. I feel like a really proud mom, and I'm really happy to be here representing my hospital and representing ALL NYC EM. So welcome. So a couple of announcements before we get started with our keynote lecturer that everyone's been waiting for. Please register. It's very important for us to keep track of how many people are involved. And a big announcement is that we are opening our ALL NYC fellowship applications. So this is mostly residents who attend this conference. For all of the residents who attend, if you are going to be a senior resident next year, so a PGY 3 in a 3-year residency, or a PGY 4 in a 4-year residency, and you're interested in a career in academics and you want some sort of mentorship and some sort of training, this fellowship is great for you. What you're going to get, it's a 1-year-long fellowship. You're going to learn about conference development. You're going to get mentored by some of the best presenters with presentation skills. You're going to help us build a medical student boot camp. We have a chief resident retreat that you're going to be part of. There's tons of networking opportunities, especially if you want to stay in New York. It's a really great opportunity. You're going to be surrounded by great people. There's different sorts of regional mentorship opportunities we offer you, and we cover your costs. This year, CORD is going to be virtually, but you will be attending CORD via us. So it's actually pretty competitive, the application. I suggest you guys start looking at the application, and the deadline is December 1st. You can find all of this on our website for more information. This is our agenda for today. We're going to finish with my welcome. We're going to move on to our keynote lecturer. And then the way this conference is going to go is we have different blocks of lectures. So we tried to pick controversial topics in evidence-based medicine. We're going to hear different sides of the story, different lecturers giving their points of view, and then we're going to have a panel discussion after every short lecture. Each lecture is about 10 minutes. So hopefully you enjoy this different style. We figure something different is always something good. All right, without further ado, I would like to introduce Dr. Scott. She is a graduate of LSU and completed her residency at Boston Medical Center. She subsequently served as the chief of service at Rutgers and MJS. She was the chair at Lincoln Medical Center, and she's now the chair of the Department of Emergency Medicine at Brookdale University Hospital. Welcome, Dr. Scott, and we are excited to hear your lecture.
All right. Thank you. I'm excited to be here.
It's nice to see you.
Okay. All right. Whoops. All right, very good. Good morning, everyone. It's a super cool to be here with you. Particularly, I feel honored to be able to be before so many emergency physicians who worked extremely hard over the past and continue to work extremely hard to manage this pandemic as best we can. I think it's very apropos that we're having this conversation about evidence-based medicine, given what we've been through and how we've really had to rely on each other and really scramble to get the best available evidence to guide our clinical practice over the past few months. So I want to start with, second. I want to start with just a kind of a brief, very brief discussion about what is evidence-based medicine to just kind of set the frame for our conversations today. So you want to just think about it as taking the best available evidence, which we'll talk a little bit more about, your clinical judgment, and then really I think what we oftentimes forget is that third piece, which is making sure that we include the patient's value, right? The patient's values and preference. So it's not just about the evidence and it's not just about your opinion, but it's also taking that patient's perspective and the patient's values into consideration when we're making clinical decisions. Now, the whole concept of evidence-based medicine actually started in about 1850. And I think another interesting, very interesting concept about having an evidence-based practice is that it's not a one, you don't take one course and you're done. It's actually a commitment over the course of your entire career to being an evidence-based practitioner, which means that you need to identify how are you going to digest the literature, digest the evidence, and this day and time, there are many ways, including attending conferences like today. There are blogs, other social media outlets, journals, etc. But if you think about it, if you go back to, 1850, 1900, it was a lot more challenging for clinicians to actually access the best available evidence. So you want to kind of figure out for yourself, how am I going to, on a weekly basis, make sure that I'm on top of the best available evidence to guide my practice. And then we must, I think it's necessary to acknowledge Dr. David Sackett. Dr. Sackett actually is from the United States. He went to medical school at the University of Illinois in Chicago. And then he actually moved to Canada. And he was the founding chair of the very first department of clinical epidemiology in Ontario, Canada. And in the early 1980s, he actually started kind of what we now consider the evidence-based movement. He really got clinicians around the world, not just in the United States and Canada, but around the world, thinking about having an evidence-based practice. And he was one of the earlier physicians to create the level of evidence ratings, which we use today. Now, what is relevant scientific evidence and how do we get to that? So there's a theory or hypothesis, and we kind of go through this progression of animal model studies, small human trials, RCTs, we repeat, and then we start to have meta-analyses, and we start to have some conversations about what we think the best evidence is. One of the things that's super fascinating in 2020 is when you look back at 1918, the quote-unquote Spanish flu of 1918, and you look at how clinicians, doctors, and nurses during that time, when they were dealing with a deadly disease that was highly contagious, and they really had no evidence. And not only did they have no evidence, they didn't even know what disease they were dealing with for much of the pandemic. They really had not actually identified the pathogen. And so what happened was clinicians just kind of, they used their own small case series. I treated 5 patients with strychnine, and I had this improved outcome. And there was a lot of dissemination of information by word of mouth The media, the other interesting thing too is like the media really was not publicizing what was actually happening from a public health perspective because there was a war, right? And so the president and the government at that time really did not want to dampen the morale of Americans. And so there really wasn't a clear picture about what was happening with that pandemic for the average bloke in the country. And I think there are some parallels, when you look at how we hear the pandemic described in the media and how there's some discourse even about like exactly what's happening. And so we've also experienced the struggle to get to relevant scientific evidence with regards to how to manage this pandemic. And right now, I would say this month and the last month or so, we've just started to have some meta-analyses and some really good solid data to drive our clinical practice for some therapies related to treating COVID-19. And so next I'm going to go over very briefly just to kind of give you kind of a concept of some of the controversies over the years in emergency medicine. I'm going to start off with acute stroke, right? So I'm sure we all are aware that there's controversy about whether or not there's actually a benefit of good neurologic outcome when using IV TPA for the management of acute stroke. And this controversy has actually been going on for almost 20 years, believe it or not. And it's largely between the neurology camp and the emergency medicine camp. And I think and my experience has been particularly challenging because I've been a leader in emergency medicine over the past 20 years or so, and really have been, part of my job has been to work with neurologists to put processes in place to give IV TPA for acute stroke. So it's really interesting, like having to kind of put these processes in place, but knowing that a lot of my colleagues have some doubt about whether this therapy is even beneficial or not. And the other interesting thing with this particular controversy is that you really have to take into consideration where you're practicing. Right. So if you're in an inner city and you've got, you're at an academic center and you have neurologists and neurosurgeons and intensivists making that shared decision along with the patient, of course, about whether or not to use this therapy. And then if there's a complication, you also have all of that backup and support to help you deal with the complication. Versus if you're a single coverage emergency physician in a rural area making this decision by yourself with the patient, and then if there's a complication, you're managing that complication and getting that patient shipped off to a more safer place. So where you practice matters, I think, when you're trying to figure out what side of this controversy you're on. And I think, more and more evidence is becoming available, and hopefully one day we kind of reach the end where we are confident about what's the best thing to do in all circumstances where acute stroke is concerned. A less dramatic controversy is mechanical CPR devices, right? These are some like sexy, beautiful toys that we some of us enjoy having in our emergency departments. But I think we all pretty much agree that there's really not a difference in ROSC survival, and particularly survival with good neurologic outcome, right? A patient-centered outcome would be a good neurologic outcome. However, again, if you kind of go back to that single coverage emergency physician in a low staffing model where there's maybe just a doctor and a couple of nurses and a PCT, some argue that these mechanical CPR devices, while they may not change outcome, it kind of helps the team get the job done. And there's actually, I referenced this, the Rebel versus the Skeptic from SMAC 2019. That video is entertaining, and they actually go over some of the controversies in emergency medicine in a comical and informative manner, and they actually cover this topic also. A more kind of recent-ish controversy is the non-operative management of appendicitis. And this year, I think within the past 6 months or so, we've actually had two very good articles published. One was guidelines from the World Emergency Surgery Journal. That's kind of, they published their most recent guidelines about the management of acute appendicitis. And then there's the reference I have below. And I think what it all boils down to is patient value and preference, and then identifying that right subgroup of patients that would potentially benefit from non-operative management, right? And I think what's interesting here is assuming the patient fits that subgroup where you think like, you know what, you have a non-complicated appendicitis, and I think that you would do well with non-operative management or antibiotics to treat your appendicitis. And you could have a patient that's like, you know what, doc, I really can't afford to have surgery now, be out of work, but if I plan my appendectomy, it'll just make my life a whole lot better and a whole lot more manageable. That's like kind of a circumstance where you take the best available evidence, you identify the patient who most likely will benefit from non-operative management, and you actually do shared decision making with your patient to come to a clinical decision about what's best. And then this one, I think we all kind of put this bit of evidence in the back of our brain when we're doing our resuscitations on a daily basis. But there's really not good evidence that epinephrine improves survival with good neurologic outcome, right? And so I think most of us probably know this, but when you're calling for the epi in your resuscitations, it feels like you're doing a good thing. But it's not necessarily true. The patient may survive in the ICU and drive up, their healthcare costs. But at the end of the day, there's no good neurologic outcome, and they may expire, within days or weeks after the resuscitation. So I do think this particular controversy warrants a little bit more discussion in the emergency medicine community, particularly if we want to try and reduce the cost of healthcare. Are we really doing right by the patient? Is it a really good patient-centered outcome when we are using epinephrine in the way that we most commonly do in resuscitations? And then I want to kind of, I have to touch upon COVID-19, and I know all of you are doing your best to stay on top of the most recent literature recommendations data. The subtopics that I have bolded on this slide, there's much more evidence to kind of support how we use these therapies. Now, reuse of the N95, I don't think any of us are happy about that. But there is pretty good evidence now that there are ways that you can safely reuse N95s if we get in a position where we have to do that. Thankfully, I don't feel like that's going to happen. I feel like we were definitely in trouble, and in many places N95s were not available in the spring. I think in the fall and moving forward, that's less of a concern. But it's nice that some of our colleagues have actually done the research to help support what would be a good practice should we find ourselves in that situation. And then the topics at the bottom: anticoagulation, awake proning, ECMO. I think we're all kind of on the same page where hydroxychloroquine is concerned these days. But those topics on the bottom, the evidence is still coming in, and we're still kind of trying to figure out what's the best thing to do, except hydroxychloroquine. I think we all agree that that's not helpful. This two-part podcast on the Rebel EM site was just published on October 13th. I think they're both about 30 minutes, and I have no financial disclosures to report, but I really found that Dr. Razy did an excellent job of covering all of these topics in an hour and really giving you like QR codes to get you to the actual articles and evidence that he's referencing. So if you haven't already taken a listen, I think it's worthwhile to do that to get yourself up to date on the best available evidence with regard to the management of COVID-19. And then I'll kind of end with a less controversial, kind of entertaining dilemma in emergency medicine, and that's like the use of IV fluids, and then which IV fluids do we use? So it's pretty common practice in emergency medicine that if you're drawing blood, you put in a peripheral IV. It's pretty common practice that if you're admitting a patient to the hospital, it's the expectation that that patient has a working peripheral IV. It turns out that we know that there's a pretty significant number of peripheral IVs that are actually never used, or we put them in the emergency department. We maybe give a bag of whatever IV fluid, most likely normal saline, even though the patient may not necessarily need that. And then the patient goes on to be in-house in the hospital, and nobody ever reuses that IV. So it really begs the question, should we have more stringent guidelines around when we actually place peripheral IVs? I think we all kind of feel like it's a relatively low risk procedure, and we just put those IVs in. The other thing is that emergency departments historically are stocked with normal saline, and that's our go-to IV fluid. But we do have some pretty good evidence that there are circumstances where we may be exacerbating acute kidney injury, and that we should be using balanced crystalloids. In order to do that, we have to change practice, stocking processes, purchasing processes, and also engage our nursing colleagues. We'd have to not just the emergency physicians, but nurses would also have to be on board with changing practice with regards to IV fluid choices. So this is another, the Center for Medical Education has a quick YouTube with Dr. Pescatori, which is actually pretty good and easy to listen to. And he kind of gives a brief overview of IV fluid choices. And then if you just Google IV fluids, normal saline versus balanced crystalloids, there's an awful lot of information available for you to kind of take a deeper dive into IV fluid management. And then I just want to finish up by saying that I really encourage you, and particularly over the course of this morning, right, to think about patient-centered outcomes, keeping our patients first, right? So all of the academic discussion, at the end of the day, the goal is to get to evidence-based practice, keeping our patients first, and doing the right thing by the patient. I think sometimes we really get, excited about new therapies, and perhaps at the end of the day, there's no real change in outcome from the patient. Maybe it costs more for this new fancy therapy, but we don't actually have a change in the outcome for the patient. So when you're listening to the lectures over the course of the day, ask yourself, does it change the outcome for the patient? Is this creating a better outcome for our patient? And that really should be at the forefront of our minds. So thank you so much, and thank everyone for being here. And I really look forward to hearing the rest of our lecturers.
Awesome. Thank you, Dr. Scott. I'm going to take over. So for those of you who joined a little late, so you're not morning people, I totally understand. Welcome. Hope you enjoy this conference. Please make sure you use the QR code and you register via the QR code over here. Quick shout out, we have the ALL NYC Fellowship that is opening up. Applications are due December 1st. It's for next year's seniors, so PGY 3 in a third year program, PGY 4 in a fourth year program. More information is on the website, so just check out the website. All right, now we are going to have a joint lecture done by Dr. Corrado and Dr. Jaira Almonte. They are both all NYC faculty members. Dr. Corrado is the Assistant Program Director at NYP Presbyterian Columbia Cornell, and he's also the Medical Student Clerkship Director in Emergency Medicine. Dr. Almonte is awesome. He's dual EM trained and PEM trained. He's also the Assistant Program Director for Elmhurst Mount Sinai Medical Center. So welcome, guys, and we're looking forward to hearing your take on this controversial topic, especially in light of COVID. Should we be doing direct laryngoscopy or video laryngoscopy? Thanks, guys.
All right, good morning. Thank you all. It's wonderful to be here. Before I start, I'm Jaira Almonte.
And I'm Mark Corrado, faculty at Cornell and one of the APDs at the Columbia Cornell program. Just click here. So what are we going to be talking about here? Specifically, we're going to be talking about how we in New York City in 2020 should be doing laryngoscopy. Now, the debate is pretty well developed at this point between video and direct laryngoscopy. But what we'd like to do is tailor it sort of specifically for you guys, for this audience.
Yeah, I think instead of trying to answer the question of what is the best way to intubate, what we want you all to keep in mind as we go through evidence in the next 20 minutes is, how should I be learning to intubate as a resident in 2020? I mean, your training time is really an opportunity for every patient encounter to maximize your development of skills. But at the same time, you have to maintain the safest possible patient care environment. And we want to figure out how to help you do that.
So look, we all recognize that difficult intubations, different airways are a bear. That's why we're using this little analogy here. You know, if you look at this cute little guy with his small mouth and his micronathia and his obesity, and you know, airway management is probably the single most important physical skill that there is for an emergency doctor. So establishing and improving best practice in this arena really is time really well spent. So I just want to start by getting everybody sort of on the same page and getting together on exactly what it is that we're talking about. You know, look at the panel on the left. Historically, direct laryngoscopy was the only option. And it's called direct laryngoscopy because you have to establish a direct line of sight, shown by that straight red line, a direct line of sight between your eyeball and the patient's glottic opening. And you do this by manipulation of the blade and patient positioning, and you know, manipulation of the airway with your right hand. And Joff, that's not always easy to do, is it?
No, I mean, I think it's really challenging in a lot of patients, and you know, totally physically impossible in about 1%. And you can't always predict who those are going to be. And so in the early 2000s, someone had the brilliant idea to put on a little micro camera on the end of a laryngoscope blade to get a better view. And so video laryngoscopy was born. And the initial kind of devices that really took off were these hyperangulated blades, like the glide scope you can see on the right, where there's a radical curve at the end of the blade that allows you to kind of get around the tongue and kind of look up at the glottic opening rather than having to develop that line of sight.
Yeah, so that's that curved red line that we see in the photo. So what these hyperangulated video laryngoscopes allow us to do pretty much is see around a corner. So seeing around a corner is good. And I think it's actually worth watching that again. Whoa. So anyway, so once there were two options for intubating, and you know, by this point, video laryngoscopy is pretty much ubiquitous in all of our departments. It led to a big debate in the literature and in the FOMO-sphere on which is actually better. Over the years, the debate it's kind of gotten heated and passionate at times. Some people are of the belief that direct laryngoscopy is a skill that's absolutely essential for emergency physicians and should never be, you know, completely abandoned. And others, you know, some very wise people, such as Ron Walls, big airway guy, he said back in 2012, "I will unequivocally state that it is wrong for people to practice direct laryngoscopy." So it's been a heated debate.
Yeah, I mean, I can't say I quite get with the Ron Walls standpoint, but at the same time, I mean, take a look at what you get between video and direct laryngoscopy. You know, wouldn't you rather have a really great, you know, close-up magnified view of the glottis like you see on the right here, as opposed to sort of like staring down a dark tunnel? I mean, it just kind of makes sense, right, that this is going to be the better way to be intubating somebody. It certainly makes us feel better, I think. And I feel like we kind of, you know, in some ways settled this debate for ourselves. I mean, you really don't know where a person stands on an issue till the chips are all on the table, right? And so this spring, we're managing all these high-risk COVID airways, and we made the decision to do it 100% video, essentially. I mean, granted, that was in part due to, you know, the theoretical risk of decreased exposure because you get out of, you know, sort of the patient's line of a spray of respiratory secretions. But also, if you look at like the COVID airway guidelines that Difficult Airway Society and others put out, they basically just said, you know, we should be doing what's absolutely best for these patients, and that's video.
Right, but I think that's what makes this question even a more important issue to be thinking about. You know, most places are now doing 100% video, sort of by default, as you say. And I think it's really easy to envision a world 3 or 5 years from now where we have a generation of newly graduated emergency doctors who have never done emergency intubation with direct laryngoscopy.
Yeah, I think it's a good point. I think, we do want to be rigorous about this before we go and throw out, entire, decades of practice. And developing that skill for kind of getting that mechanical line of sight is probably important. But I mean, there is good literature that, at least for novice intubators, training in VL alone does improve your DL skills. So do we have to be doing this, in these high-risk emergency airways?
That's true. But what, it improves their DL skills, but what about developing real expertise? There's also literature to suggest that institutions with a high VL utilization, they see an erosion of their DL skills, which suggests that you really need to be doing DL to really establish and maintain expertise at it. So anyway, guys, these are some of the sort of passions of the debate, which, like we said, has become heated at times. But this is an EBM day, an evidence-based medicine theme day. So our job is going to be to put this big question of what is the better way to be doing laryngoscopy into the context of the literature that we have available to us. So let's kind of see where we stand. So, Jeff, is there any reliable evidence for the superiority of video or direct laryngoscopy?
Yeah, it's a good question, Mark. There's a ton of literature out there. I have to say, whenever I'm encountering the big field literature and I want to see what the answer is, the first place I'll go is the Cochrane database and look for a good Cochrane review. And thankfully, they did one on this topic back in 2016. It was like a huge effort, like 64 randomized controlled trials, all comparing various VL devices to DL. And I think we both looked at it. So, I mean, what was your take on this?
So at the time, their findings were really pretty significant. And it really propelled the argument for a total switch to video. They found a big advantage for video in terms of preventing failed intubations. They didn't find much of a difference in terms of first pass success, but they found that 1 out of every 14 video intubations would have failed if direct were used. And at the time, that was a really significant argument in favor of video.
Yeah, I mean, I guess, so if that's such robust data, then why are we even having this discussion?
Well, with that and kind of with the other evidence that we're going to talk about shortly, there's some really important and significant methodological problems with that meta-analysis. And the biggest thing is that, of the 64 studies that they included in their analysis, 7,000 patients or something, really only one of those studies, arguably up to 3, but really only one of those studies was really conducted in an emergency department. Most were from the anesthesia literature. So, the first really big problem is that, is with applicability to emergency medicine.
Yeah, I think that's a really good point. I mean, we can all agree that sort of elective anesthesia airway management is a different skill set and different procedure than emergency airway management. I mean, you got a person who's, been fasting for 8 hours, getting ready for their, elective plastic surgery procedure. It's fundamentally different than intubating and crashing GI bleed on resuscitation day, right?
Yeah, and in that same vein is the problem of who was doing the intubating. Just as they weren't done in emergency departments, the operators weren't emergency physicians. The studies ranged from anesthesiologists to folks they just referred to as, non-anesthesiologist physicians. We all know any tool is only going to be as good as the person using it. And in these pooled studies, it was a pretty heterogeneous group of intubators. So, all this means it's just not really a reliable way to know that, if we in the emergency department are more likely to have success with VL over DL.
Yeah. I think that generalizability EM is really important to think about. And also, I want to go back to something you mentioned earlier, that they really found no difference in all comers in terms of first pass success. And I was one of their secondary outcomes for the study, but I think as EM providers, that's really what we ought to be looking at when we decide what to do, right? Because we know that even one failed intubation attempt significantly increases the risk for adverse events during airway management. And so the question I asked myself looking at this is not so much which method best gets the tube down eventually. The question is which gets the tube down first on the first pass, the first time. And there was no difference between these two.
Yeah, and so take that, and then, with that in mind, let's mention another, the other sort of big important meta-analysis, and that was from 1 year later. That was from 2017, published in the journal Critical Care. And in that one, they pulled data from 12 randomized controlled trials, about 2,000 patients in total. And in that one, all of the pooled studies were conducted in emergency departments or ICUs. And that was in contrast to the Cochrane review. And in this study, they found no benefit in video laryngoscopy over direct. So that's probably a little bit more like what we're looking for, isn't it, Jeff?
Yeah, I mean, I think that's definitely our patient population. And important to note, even in like they did subgroup analyses by location, and there was no difference in the emergency department subgroup analysis either in that study. And it's been criticized that the studies they looked at were pretty heterogeneous in terms of the patients they included, and several of them had some substantial methodological weaknesses, including potentially excluding difficult patients. But I think it still remains kind of the best prospective evidence we have to answer this question.
Yeah, I mean, it's the best we have, but like you're talking about apples to apples, that really seems to be the theme with the available evidence on this topic. The two big meta-analyses that we talked about, and most of the other literature too, by the way. There was another meta-analysis around the same time, which pooled 5 randomized controlled trials. There was a 2017 article that made it into JAMA from France that gets cited a lot. And there's been a handful of others in the last 5 years. But the consistent theme is that, for such an important matter as this, the methods used to study it really have not been as rigorous as we would like. They've not been that rigorous.
Yeah, I guess I don't know if it's not that they're rigorous, but it's just that it's a really difficult topic to study in like a randomized controlled fashion, right? Because it's hard to consent and enroll patients for a study when they have to be emergently intubated. I mean, generally they're not very communicative, and it's hard to obtain consent from them. And there's this question too, when we try to sort of pool these studies together, of are we really comparing apples to apples? Because they're looking at several different device types across these meta-analyses, which might have some device-specific benefits that we're missing out on.
Yes, I mean, you're absolutely right. So it gets really clouded. This is it's a tough thing to study. For the reasons that you mentioned, and then also when you consider that just the act of intubation, the procedure itself is really hard to study. We're talking about things like time to intubation from when you begin the attempt, or hypoxia, and these things they're hard to study. So the saturation goes down to 78% for a few seconds. Does this count as hypoxia? Was the blood pressure cup off? Did the probe fall off the finger? It's just really hard to take rigorous measurements of these things during unplanned emergent procedures. So, look, something that we obviously agree on is that all of the research we've mentioned so far is sort of flawed. Looking at the left panel, it kind of gives this picture of nice intubating conditions that don't really exist in reality for us. So something I'd like to bring up is a more recent study from earlier this year, February, published in Academic Emergency Medicine. And Jeff, you and I disagree a little bit on this one, but I think that this one does the best job so far of studying the question of video versus direct in a way that replicates our real life practice in emergency rooms. It was an observational registry study, and it was done only in EDs, both academic and community, so good generalizability there. And they compared video to direct, and they used both hyperangulated and standard geometry video blades, and they did separate analyses for those. And importantly, the direct intubations were looked at sort of under real world conditions. In other words, they were trained operators, they were emergency residents and attendings, and they looked at them separately, and they allowed them to use a bougie if they wanted to use a bougie. If they did some laryngeal manipulation with their right hand, they looked at that separately. patient positioning, ramping, et cetera. In other words, the DLs that they looked at were done under sort of real world conditions. And their results were pretty convincing. They sort of resoundingly say that video wins. They say that you're 1.5 to 3 times more likely to have first pass success without hypoxia using video.
Yeah, this is a great effort, and I think the NEAR registry is probably the most robust sort of data collection on how emergency intubations actually happen in the real world. But like you said, it's a retrospective study, so there's always potential for recall bias, right? People are collecting all this data about predictors of difficult airways and how tough the airway was after they did the procedure itself, and sometimes several hours after the procedure. So recall bias exists. And I can't, kind of get past the fact I think these are really 2 different patient populations, right? They looked at people who had DL that required some sort of augmented maneuver as opposed to VL where they just, did nothing except stick the blade down the throat. And though you said in the study they were essentially equivalent, if not the VL group was a little bit harder to intubate. They just sort of seem to me like very different patient populations. But regardless, I think this is a finding we see in most of the retrospective studies, is that sort of in observational studies, the video seems to do better, but that's not really been borne out in prospective research. And kind of the mantra in EBM is always that prospective studies, because they have a decreased risk of bias, really should trump or provide us a higher level of evidence than retrospective and observational cohort studies. And so I think we see, the way I read this is there's a strong signal in data, but there's nothing definitive. And so we're at a point of, I think, essentially equipoise in this question.
Yeah, so I think it was brief, but I think that's a fairly honest tour of the evidence that we have so far. And while we disagree slightly on the recent NEAR paper in Academic Emergency Medicine, you and I, we definitely agree that the superiority of video or direct is not at this point firmly established by the evidence.
Yeah, absolutely. But I mean, we still have to make a decision, right? We have to decide how we're going to, train and practice intubation in the real world. And so we have to rely sometimes on other things besides evidence alone. There's, pathophysiology and experience, and to some degree kind of, art and I guess even philosophy of practice.
Yeah, and speaking to the potential conflict between the data that are available and sort of the philosophy of medicine, to me, regardless of what the evidence might actually or eventually come out and decide on the superiority of video or direct, my question is it irresponsible to hinge a patient's life on a piece of technology? Like we said before, airway management it's the most important single physical skill that we have as emergency doctors. And there can be camera failure. You can get blood or vomit or secretions on it, and that can just totally incapacitate the VL. Now, you're in a situation where you've just paralyzed a person. You've taken somebody who was breathing and you've made them not breathing with plans to insert an ET tube, and you risk technology failure. You're literally betting someone else's life that this equipment is going to work. And to me, that's really serious. And I think that we shouldn't necessarily be depending upon technology. It's just too important. Yeah,
that's a good point. I think that, and we also want to be, training people who can practice places where, video might not be available, because it's not entirely ubiquitous across the world yet. And I think anecdotally, we can certainly think of cases where people have been impossible to intubate via video laryngoscope, and then were actually fairly easy via DL. And unfortunately, there's not a lot of data capturing kind of who this patient population is, but I think we can all think of at least 1 or 2 cases of our careers where that's happened.
Yeah, so, okay, so those are the types of questions, guys, that, I think exist outside of the evidence, independent of the evidence. And, it's tough that, we're not debating here per se, Jeff and I, but, I will say this, that regardless of which way the evidence might lean, I think that we should not be abandoning direct laryngoscopy as a mechanical skill.
I think that if there were overwhelming, convincing evidence of the superiority of VL, we have to do, as Dr. Scott alluded to, sort of what's best for our patients and keep that primary. But I think at this point that has not been shown, despite a plethora of evidence.
So, all right. So back to the initial question. How should we be learning laryngoscopy in New York City in 2020? You guys are residents training here. So we've kind of taken a survey of the literature for you guys, and it's not convincing either way in favor of video or direct. We've brought up some philosophical questions for you to think about independent of the available evidence. So I think now you guys possess the key tools that you need to think about where you stand individually on this debate. And we're going to tell you where we stand, because this is, where we stand, where we conclude, we agree on this.
Yeah, I mean, I think there's lots of right answers, but probably but I agree with you, Mark, that we do need to, at this point, keep up our mechanical skills of DL. And there is a way we can do that, potentially while not losing the advantage of VL also. And so, I mean, in addition to hyperangulated blades, we have standard geometry Mac blades. I think some people mentioned this in the chat to the panelists also, but there are standard geometry Mac blades that allow you as an operator to do DL while your attending can look at the screen and kind of give you real-time feedback and guidance. And that kind of makes sense. It's going to help you, and the literature supports the idea that having attending looking at the screen and kind of coaching you through the procedure increases your first pass success as a learner. And so I think for all of the kind of non-COVID airways, or at least most of them, that's probably the best way to approach learning laryngoscopy in this time, and probably also with the bougie, but we didn't really touch on that, but probably with the bougie as well.
Okay, so that's where Jeff and I come down on this. Just to kind of put an exclamation point on it, our position is that the way to proceed is with a standard geometry blade with video, so that you can have the mechanical skill of direct laryngoscopy and learn that, but without sacrificing the benefits of the video. So that's our verdict. And just one more thing before we finish that we both want to kind of convince you of is, with this issue, and probably with a lot of the others that we're going to talk about for the rest of the day, you guys may see yourself as sort of bear cubs in the EM forest. But everyone in this audience, all of you residents, you've got somewhere between 7 months and 43 months left in your EM training, and that's it, and then you're done. And it's really important that you understand that you are the drivers of your own education. It's you and not your faculty that are going to be the primary determinant on whether or not you learn direct laryngoscopy as a skill. I think every ED in the ALL NYC consortium has the equipment available to you. And it's going to be you guys who are going to decide the future of this DL versus VL debate. And hopefully we've done an okay job in, sort of arming you with a framework within which to think about it. So that's all we have. Happy intubating. And Jeff, it was a pleasure. Thank you.
Thank you.
Thank you guys for that awesome lecture. So now we're moving on to the panel discussion. We have some questions that we thought would be relevant to discuss. We also have some questions that opened up in the Q&A in the chat, so we'll be going through them. First, I'd like to introduce Dr. Odufunade. She is a Nighthawk attending at Harlem Hospital. She's also the director of podiatry student clerkship in emergency medicine. I know you are very opinionated on this subject. You work with residents. You also work without residents. So I guess the question after hearing this lecture is, are you doing DL or VL alone with residents? What's your take on this subject?
Pre-COVID, I was definitely for DL. It was, while we learned video as well as DL in residency, I would definitely say, at least my training was definitely more skewed towards direct. So I'm way more comfortable at direct versus video. During COVID though, that changed. In our department, we were fortunate enough to have anesthesia come down and do our intubations, and they were using a CMAC. In the event that, you know, our attendings did need to intubate, we were in full PPE. We're still using P100 masks, not even N95s, full face mask, and depending on who was intubating during COVID, if it was the attending, depending on what they had at their, what they had available, some were doing direct, some were doing video. As for me, even during COVID times, I still feel more comfortable doing direct. I feel like that's the fastest way I can get a tube in. But if I'm working with a resident, I tend to lean towards video.
And I definitely think that's a good point. It was brought up in the chat as well. It also depends right now, practically speaking, the patient in front of you, what are you comfortable with? And a lot of attendings are more comfortable with direct. So the goal is to get the tube the fastest, safest way possible. And for some people, it might be direct. But I guess the question for the group is, if we have N95s and face shields and P100s, and we also don't know who has COVID anymore, right? We have reinfections, we have people with atypical presentations, people who don't come in with any history. We still are assuming everyone is COVID. So how are we intubating, and why should COVID change that if we technically have all of the protective gear? This is for everyone on the panel.
Yeah, I think that it kind of just, there is some truthiness, sort of makes sense. The idea that if you don't have your face in the direct line of sight of the patient's face, that you're at a lower risk despite all of the PPE. I have not seen any data that really supports that, but it kind of makes sense. And I think there are a couple of questions there. One is, as educators, we're obligated to keep our trainees as safe as possible. So there's any possibility that doing VL is safer than DL. I think having trainees do that, it makes sense from that standpoint. But again, I think that's more of there's no strong data. The only thing I've seen is that in simulation studies, they actually measured the face distance of people in VL versus DL. And so you get about 6 inches more distance out of line of sight in VL. So I think that's an argument for VL in those situations. But the other thing is, like you said, some people are faster with DL. And there is some comment on the chat about sort of VL is faster. I think that's actually in the literature not up for debate. In many studies, VL actually took longer than DL. And so it's not clear which one's actually a speedier way to intubate. But I think you're right. It might depend on per provider. Everyone's going to have different rates of first pass success with different modalities. And so it does make sense to stick with what you're most comfortable in these sort of high stress, high risk intubations, I think.
And also, you know, we mentioned, so 6-inch difference to me is not a ton of difference in terms of, am I getting COVID from this patient or not, if I'm not properly protected, right? But most of us, almost all of us on this panel, work with residents. We're leadership in our departments, and COVID's going to be around for a lot of our residents training. I mean, it's been going on 6 months. It might be going on another year. I'm at a 3-year residency, so I can't afford to let anesthesia always intubate or to let my residents always do video laryngoscopy. So how do you guys take the information that was presented in the lecture that you know, practically speaking, in the ED, and make the best decisions for your team? Because COVID's here to stay for a long time.
Yeah, I think the silence after you ask the question is really telling. And you know, this is the lamest answer that you can think of, but it really, I think, is a case-by-case decision. It's going to depend on who the learner is, who the patient is, and who the faculty is guiding it. You know, as we said, generally we've shifted. Most places have shifted to all video all the time. But you know, you bring up a great point. All video all the time for your entire residency means that this is a skill that generations of EPs before you have had, and you've been deprived of. You know, and I think for the residents in the audience, I think it's kind of telling that, you know, several of the attendings in this panel have mentioned, oh, you know, I like to do DL in these situations, or this is why I prefer DL as my first choice. And regardless of what you think of the merits of what their decisions are, you must at least acknowledge that there's a certain benefit to having that option available to you. If you go for your whole residency and never experience DL, you will be an attending and you won't even have the luxury of that option.
Yeah,
I
and
completely agree with that. Yeah.
I wanted to send it back to you, Dr. Otofanati, because like I said, you work overnights where there's less coverage, you work with residents, you work without, and a lot of our residents who graduate from here are going to work at single coverage places. There may not even be anesthesia as backup. And we all know that you cannot intubate a variceal bleeder with video laryngoscopy. It's not going to happen. So what are your thoughts?
At least when it comes to the more senior residents that were training pre-COVID and got used to dealing with direct, a lot of them even feel more comfortable doing direct over video. So I try to, if that's what they feel more comfortable doing, that's what I let them do first. Mainly because, I think it's great to hone in on a skill that you're better at. But having said that, I guess what worries me is our interns or our second year residents that got caught up in COVID, like the second half of their intern year, or, the beginning of their intern year. And the fact that in their learning, it's more video than direct. I saw in actually my old program director, Dr. Pereira, Tom, had mentioned something about, using video just to get used to the anatomy and then eventually going to direct. So you have more, at least I believe that's what he said. So you have more of a sense of what the anatomy is supposed to look like. And I think that that's at least when I think back to when I first started intubating as an intern, I think that was the biggest thing for me, getting used to what the typical anatomy is supposed to look like. Because, when you do it via sim, all of those are just perfect pictures of what cords are supposed to look like and stuff like that. And we all know that in a real life situation, that's not how it is. So I do think that at least starting off via video, especially with our interns or second year residents that haven't gotten as much exposure to direct, starting off with video, just so you have a sense of what the anatomy is supposed to look like in a real patient, and then pushing them, as long as it's within their comfort level, to try direct. And clearly if they're having difficulty, either switching to video or the attending taking over.
And I think that's a good thought process and a good approach, is maybe get used to the anatomy with video and then move on to direct. But what that means, well, so first of all, I think there's a common misconception with residents that if you can intubate with video, you can't intubate with direct, or vice versa. It's different technique, right? It's completely different technique, the intubating, and not everyone realizes that. Or even people who've never done video, senior attendings who are now learning video, it's a different technique. So it's hard to just transition over. And then I think it's good advice, but I think then the residents are going to have to take the ownership to make sure, okay, what am I more comfortable with? What have I been intubating with? And if I'm really comfortable with video because I'm an intern or I'm a graduating intern going into PGY2 and I've always intubated with video, I have to push to get direct. So it's definitely will come up to the resident themselves to push and advocate for their education. But then it's tough. Some of us might not be comfortable letting people do direct nowadays. So, and again, I think the biggest overall message here is we need our patients to be safe. And I personally feel that the safest thing is for physicians to know how to intubate in every different manner. And you have to protect yourselves. We have the personal protective equipment available, thankfully, but we have to graduate residents who know how to intubate with DL and VL.
Yeah, I think that you mentioned that about the technique is really important, and that even within VL, the techniques are a little bit different between the hyperangulated blade and the standard geometry blade. And I think this using standard geometry gets you a lot more of the same, having to exercise good soft tissue control and get some degree of line of sight that more approximates, even if you're using it primarily as a video methodology, it approximates what you do with DL. And the two major systems both have standard and hyperangulated blades. And to think that training as much as you can with whichever system, a standard geometry blade, whether it's primary video or or direct is gonna be more crossover between those skills than if you're doing all video hyperangulated blades and then try to learn to do direct from that, or even vice versa.
Now, Dr. Otofanade, I know you're more comfortable with DL generally. So for Dr. Almonte and Dr. Corrado, when you are intubating without a resident, do you have a preference direct and video? And do you have a preference for your residents? Today, down in the ED, a patient comes in and you have to intubate. Does it matter if you're intubating by yourself or with the resident?
Yeah, I guess it matters. Generally, I don't have a good defense for what I'm about to say, but generally I do direct laryngoscopy first. It's just what I'm more comfortable with. I'm getting increasingly facile with video, but when I'm intubating by myself, it's usually direct. As is more often the case, though, as we all know, we all work in the same places. Oftentimes when the attending gets to intubate, I'm like third online. It's the junior fail, senior fail, attending, and now it's bloody and edematous. So in those situations, I'm one guy, N of one, but in those situations, if the resident was having a difficult time with visualization, then I will often switch to whatever they weren't using. But if the resident was using video and there was good visualization, and for one reason or another they weren't able to pass the tube, a lot of times I'll stick with that. If the blade's already in the patient's mouth. But I'm just one guy interested to what others have to say.
Yeah, I do this. I think I'm probably the same way. If they were doing video and they saw the screen and just couldn't pass the tube, saw the cords on the screen and couldn't pass the tube, I'll usually pick up the video. If I'm starting off on my own, I will pick a standard Mac blade with video, and then usually do DL with a bougie using that. And if I have problems, then sort of transition to video in the same attempt.
And there's been a lot of chit chat on the chat talking about how now we have video. So we have, let's be clear, video laryngoscopy means you're looking with a video to see the cords. You're not looking directly in the cords. But we have different adjunct devices like the CMAC, where the resident is theoretically going in via direct. The attending can watch, and you talked about it in your talk, right? But not every video laryngoscopy has the same type of blade. Some are hyperangulated, some are not. So there's been a lot of chatter about, well, if you have a direct laryngoscopy blade attached to a video, you can have the attending teach the resident direct laryngoscopy. So yes, that would probably, I think we all agree, would be the ideal scenario, is you continue to teach direct, we can watch. Not every place has that as well. I think it's important to remember, you also have to learn how to use a hyperangulated blade, right? So it's not just abandon the hyperangulated video blade altogether. You have to know how to do every sort of different technique. But I do think we probably all agree the best scenario would be direct blade with the video, do CMAC, I can teach you, and you get all of your skills up. But we're not always going to have that, and half the time the equipment's broken. So I think that's important to remember. There was one quick question, and I don't know if you, Dr. Corrado and Dr. Almonte, have the answer. Is there any literature on bloody airway? Which one is better? I mean, it seems like we all anecdotally, I know that I can't intubate with video if it's a very bloody airway, but is there any literature on that? Or is it just common practice?
So there was, there's a group in Phoenix that has a big airway registry. They've done a bunch of retrospective studies. And they looked at people with contaminated airways and found that there was equivalent success with VL and DL in their contaminated airways. I can point out in their studies, their VL success across all their kind of published study, or DL success, sorry, is much lower than kind of the sort of what we accept as standard first pass success. So I think that's one of the institutions where it seems like their DL performance just isn't quite as good in what they published and what we might expect based on historical controls. But in their published study, there was no difference between the two in contaminated airways.
All right, awesome, guys. So I think that's all the time we have for the panel discussion. Dr. Otofanade, thank you for joining us. Thank you for a different approach than our lectures that we had up here. And we're going to move on to the next topic. Thank you, Dr. Almonte, Dr. Corrado, and Dr. Otofanade. So Quick reminder, scan the QR code, please. We'd like to keep track of how many people are attending so we know what type of Zoom packages to have, what type of conferences to build. The next topic we are going to talk about is, I think, going to be a little bit more polarizing from what I know about my two faculty members. We are going to have a discussion as to which central line we should be doing. Should we be doing ultrasound guided IJs or subclavian lines? And the first lecture that's going to go is by Dr. Saigan, one of my good friends. He's also the assistant residency director at New York Presbyterian Brooklyn Methodist Hospital. And he's going to talk about more of a pro-subclavian central line approach. Take it over.
Thank you, Dr. Adamakos. And I'm super stoked and absolutely humbled to be part of this panel of great speakers. So I was tasked with, or kind of volunteered, to discuss the subclavian side of this central line controversy. And as I was preparing this talk, the number 3 just seemed to keep coming up. And I don't know if it was my infatuation with number 33, or if it just truly presented itself that many times, but I can't help but discuss my topic in sets of 3s. So first, I'm gonna give you some 3 disclaimers, followed by 3 questions that will hopefully will shed some light on this subclavian topic. And then I'll give you 3 tips so you can hit that target, which is that juicy subclavian vein. So to start with disclaimers, I want to get right to it. The first disclaimer is, unfortunately, I am not a dinosaur just yet. I graduated residency from Staten Island Hospital in 2015. And I say this because subclavian line wasn't the only line at my disposal. In fact, ultrasound guided IJ probably was. But I was fortunate enough to have seasoned attendings teach me this and pass on this gift so I can be confident enough to practice and teach it. Disclaimer number 2, I am no cowboy, despite my miserable attempt to look like one, the one time I went to Montana. Look at those jeans and the boots, yeesh. But in all seriousness, I'm not this tough guy ER doc who needs to plead subclavians in every single patient. I think I practice careful evidence-based medicine. Disclaimer number 3, I don't hate ultrasound. In fact, I love it. Before being introduced to this fleet of ultrasound machines at my current shop, which is a robust ultrasound department, I was trained in it to become a regular part of my practice. So now that the disclaimers are out of the way, let's get to our questions. First question, what makes the subclavian better out of these 3 choices? And in particular, what makes it better than the internal jugular? One thing I can tell you, it's been around for a while. I'm gonna take you to France once or thrice over the next few minutes. But there was a French paper that in 1952 that first introduced the subclavian line, as opposed to the internal jugular, which was proposed in late 1950s, early 60s. But just because it was introduced first doesn't mean it should retain its first position. So why is it better? You know, given that the location of the line doesn't really change its function, we have to look at the long-term and short-term effects that it has on our patients. In particular, the long-term effects of central line catheterizations are infections and thrombosis. So first take a look at our trauma patients. And this paper looked at which lines had more infections in severe trauma patients. And it's an important subset of population because this is a situation where our hands may be tied, where subclavian is our primary location. So what did they find? Infection was significantly less in subclavian lines, and even so much so that they recommended rapid switch to subclavian lines if an IJ or femoral was placed initially. So that's our trauma patients. And I'd be remiss to be speaking about infection in 2020 without bringing up the 3 letters of the CDC. And they actually have their recommendations as well. And of course, it was their 3rd bullet point that they recommend subclavian site over the other 2 to minimize infection risk for non-toned CVC placement. So if that's not enough for you, let's go back to France. 63 years later, after the initial paper in 2015, a group in France, of course, called the 3-site study group, published this paper in the New England Journal of Medicine, and it looked at the intravascular complications of all 3 sites. So what did it find? And I want you to focus on the orange and red as I conveniently shade out the first part. Of the 3 choices, when they had the choice of the 3, you can see that infection again was significantly less in subclavian, and as well as thrombosis. So that kind of tallies up our long-term risks of these lines. But the one that's mostly considered is the short-term risk of sticking a needle in the patient's chest. So is it safe? Okay. And then we'll go back to France for the 3rd time. And while the primary goal is to is to compare the 3 choices of this study. They actually did a head-to-head analysis when one of the lines wasn't available. And I know this is a busy slide, so don't strain yourself, but I want you to focus on this number here, and I'll blow it up for you. When subclavian was compared with jugular, it had more pneumothoraces, sure, but the major mechanical complications was also included bleeding and hematoma. There was no significant difference, which means subclavian was not inferior to jugular when it came to safety. So it was just as safe. Which brings me to my third question. Should we be teaching it? Should we be learning it? Should we be practicing it? It's 3 questions in itself, but should we be teaching it? And that answer is an absolute yes. We are the jack of all trades in the House of Medicine, and we are expected to do procedures in all types of patients. When I go on vacation, I don't be limited to the places that I want to go. And just like when I want to put a central line, I should not be limited with options as well, because you never know when this patient's going to come in with distorted head and neck anatomy. You look down and the femoral site is cellulitic or a big pannus that makes it difficult. This patient's going to need a subclavian line. Or how about the patient with an open book fracture that has a pelvic binder? And then you have a trauma attending, your colleague that says, don't take that C-collar off. This patient's going to need a subclavian line. And I worry about it because we're doing them less and less, and we're going to become less good at it. This survey from 2014 showed that emergency physicians are doing it less and less. You can see that 40% of these attendings over a year did zero subclavians. And this is a concern. If we continue down this path, the subclavian line is going to turn into the high acuity, low frequency procedure like a cricothyrotomy, and that shouldn't be the case. And I implore that to the attendings in the group, to be that teacher that the residents can go to and say, hey, I want to do subclavian today. I want to learn how to do it. Pass along the gift that hopefully is passed along to you. So how are we going to do that safely? And here are my 3 tips. And while I hope I still have your attention, in this world where seemingly everything is very easily canceled, I'd like to propose to everybody to cancel the term blind subclavian, throw it into cancel culture. While I understand I'm not visualizing the needle tip, I've yet to close my eyes or put a blindfold on while I perform or supervise the procedure. It is a landmark guided technique, and that's the way we should identify it as such. We use our in-depth knowledge of anatomy to perform it safely. And the anatomy really hasn't changed. 3 years after that initial French study, this Canadian journal actually spoke about the anatomy. Inserting a large needle into the chest of the subject appears frightening at first sight. It should not be undertaken without accurate knowledge of the topographical anatomy of the retroclavicular region. And thankfully, human anatomy hasn't really changed. There's a beautiful clavicle. One part, the first part of the clavicle that we need to focus on is that midclavicular line. If you hit the bone with the needle lateral to that midclavicular line on either side, you should be safe. And we're going to be aiming towards the suprasternal notch. Now, most of you should know this, but sometimes we're not going to get flashback. So on to my first tip. I'm going to move on to our real-life patient. Another disclaimer, no residents were harmed in taking any of these pictures. But you'll see our midclavicular line there. Put the needle right just lateral to it. You see my index finger is pointed towards the suprasternal notch. That's my target. I'm going to go in that area. And as I aspirate, I'm going to pull back. What if I don't get a flashback? The way to adjust the needle is you want to go into the cephalad or cranial fashion on your second direction. Doesn't need to be a puncture, second direction. And why is that? This figure illustrates that the subclavian kind of courses above the clavicle to meet the internal jugular to get to the brachiocephalic trunk. So aim upward if the suprasternal notch isn't successful. Tip number 2, and it's probably most important in regards to safety. You really want to keep that needle and syringe as parallel to the ground as possible. And I understand undoubtedly that humeral head is going to get in the way, but you want to get as close to a 0-degree angle as possible. You use your thumb to push the needle underneath the clavicle so it walks underneath, and you aim towards the suprasternal notch. Whenever I see a resident do this, increase that angle, the procedure should probably be abandoned because that increased risk of pneumothorax and bleeding as well. So on to our third tip, and this is pretty easy one, pretty simple, but guess what? You shouldn't try more than 3 times. And this is a paper, or a large clinical series that evaluated 300 landmark central lines. And they compared characteristics to see which ones had the more complications. And it was interesting to see that BMI and even experience of operator had absolutely no significance. However, once you got more than 3 punctures, it was more dangerous and mechanical complications went up. So to recap, which is better long-term? Subclavian has less infection and less thrombosis. Is this subclavian safe? It sure is safe enough, non-inferior according to the 3-side study. Should it be taught, learned, and practiced? And that is a resounding yes. And then the tips to hit the target: aim towards that suprasternal notch, adjust cephalotocranial, make sure that syringe stays parallel, and then of course, 3 strikes and you're out. So I thank you, and I turn it over to Dr. Pardeep Thandi.
All right. Thank you, Dr. Zygon. Thank you, Luke. My name is Pardeep Thandi. I'm coming from the Brooklyn Hospital Center. It's an honor and I'm humbled to be here today. So thank you for everyone for your time. So let's just get right into it. Let's pick up this debate here about the ultrasound guided IJ versus the blind subclavian. So say after your conference today, you have to work, but you come in and the first thing you see is a sick patient. You look at the IVC, it's collapsed. And you look at the monitor and the map is less than 65. So of course, the first thing you are is excited. Why? Because you are going to do a central line. And you have 3 places to go that we just talked about, right? We have our internal jugular vein, our subclavian vein, and our femoral vein. And you're wondering which one is the best? Where should I go for this patient? You're basically asking yourself, who is the GOAT or greatest of all time of central lines? And depending who you ask, you could have very different opinions on who is the best. So in honor of the number 23, I'm also going to give you guys 3 reasons why it's clearly the ultrasound guided internal jugular. Let's first talk about some theoretical considerations. There's this idea of compressibility. So what am I talking about? Well, we're obviously trying to hit the vein when we put in a central line, but unfortunately, sometimes there's things called arteries that are nearby that we hit. If you happen to hit the carotid artery when placing the internal jugular, that could be okay because this is a compressible site. Unless you do really strong exercises at the gym with your sternocleidomastoid, you'll still be able to put direct pressure onto your neck. Let's contrast that to the subclavian site. You can see here that if you happen to hit the subclavian artery, there's a big thing in the way that's going to prevent any compression. It's called the clavicle, and it's strong. So that no matter what you do, you can't compress it. This is particularly important on patients on anticoagulation or who are known coagulopathics, like our cirrhotics. And it's actually contraindicated to use the subclavian site in these patients because it's a non-compressible site. All right. Now let's move on to the most obvious thing in the room is this idea of sight. And what am I talking about? Ultrasound. Ultrasound brings so much to the table. And so we have to go into some of the things. So when you're trying to go down this road or you're trying to get this vein, you might find a block in the way. One, you could have abnormal anatomy, but even if your anatomy is the same, you might see one of these in there. A nice big hyperechoic structure right in your vein. More importantly, you could push down with your probe and you might not get any compressibility. So you might have a non-compressible vein. What does this mean? It means you can't place your central line in there. Doesn't matter how good you are. If there's a big DVT sitting in your vein, there's no way you're going to be able to get the line in. And without the ultrasound probe, there is no way to tell until after you're doing the procedure that there's a big DVT there. And that is particularly important in patients that have underlying malignancy or our sick patients are already more prone to having DVTs. Okay, but say the vein is patent and your patient's not at high risk for DVT. Why fly in the dark when you don't have to? Ultrasound allows you to see exactly what you're doing in real time. You can see your needle tip go directly into the vein that you want. And more importantly, you can avoid surrounding structures that you don't want to hit, like arteries. Even more so, a lot of these patients are hypovolemic and they have respiratory variation in their veins with inspiration and expiration. So you might be trying to hit this target and not even know it without the ultrasound. The ultrasound allows you to time it that you can actually advance your catheter during expiration to increase your chance of getting the vein. Then once you get your needle in, of course, after you have to advance the guide wire. After putting in your guide wire, you then dilate. But sometimes, even after passing your wire, you're still not sure if you're in the artery or the vein. And the color of the blood is not the best way to tell. You put on the probe, a longitudinal view, you can actually see the guide wire go into the vein before dilating, because the last thing that you want to do is dilate the artery. Lastly, of course, you put in your line, you feel good, you got your cell stuff off. The nurse wants to know, doc, can I use the line? Can I use the line? You want to get that lever head hanging right away. We usually confirm this with x-ray, but with the ultrasound already there, you can get a subxiphoid view of the heart, take your saline flush it, and in real time, immediately see that saline go into the RA and RV. This to me is good enough to confirm placement and avoids waiting the time and delay for x-ray to come by. But that's just how I see things, and that's just some theory. But we're here to talk about evidence. So what is the evidence behind this? So we just saw the 3-site study from France. So I'll bring up France again. And it was a great study, and it was done in multiple ICUs. And there's a great table, and there's a lot of great data there. But let me just give you the bottom line. The subclavian artery had higher incidence of pneumothorax. The internal jugular had a higher rate of infections. So what's worse, the pneumo or the infection? Well, I have a take on that. So there's been multiple studies, including this one in the New England Journal of Medicine, that showed an intervention can decrease catheter-related bloodstream infections in the ICU. So we call this CLABSI. And there's multiple studies that show that certain interventions can decrease CLABSI. And what is that intervention? It's simple: proper sterile technique and standardized checklists. And these studies, including this one, have shown up to a 66% decrease in CLABSI with just these two simple measures. So I would argue the risk with infection that we saw and we're seeing with the internal jugular, with just two simple measures that we should be doing anyways, and that most hospitals are doing anyways, this can be prevented. Compare this to this complication with the subclavian, the good old pneumo. And now it's really cool to do chest tubes, and we want to, but we shouldn't be excited about the ones that we cause ourselves. And this is not a good indication for it. All right, now let's go back to the ultrasound, my favorite thing. Is there any evidence supporting the use of ultrasound for central lines? Well, this would be the perfect study for this debate, of course. A blind subclavian versus an ultrasound-guided internal jugular. But that study doesn't exist. However, there's plenty of studies looking at site-specific areas and the use of landmark technique versus ultrasound technique. So in this case, the landmark internal jugular versus an ultrasound internal jugular. And this Cochrane review that came out in 2015 did a great job at summarizing this. Ultrasound guidance versus anatomic landmarks for internal jugular vein catheterization. They looked at 35 trials, 5,000 patients. So this is a big review. Let's see what they found. So for our ultrasound group, we had lower rates of arterial puncture, less hematoma formation, decreased number of attempts, and shorter amount of time with using the ultrasound versus blind internal jugular. All right, not bad. Now, what about success rates? Well, the blind group had an 87.6% success rate, the ultrasound group, 97.6. Complications in the blind or anatomic group, 14% versus the ultrasound group, 4%. So the evidence is clear that the ultrasound internal jugular has less pneumos, higher success rates, and lower complications. Now, what about the guidelines? Because there's great evidence, and evidence is important for patient care, but guidelines are really important because this is what experts in the field in our societies are reviewing all the evidence and coming up with standard of care recommendations that we should all be following. So let's look at a few of them. The American College of Surgeons recommends the use of ultrasound for all central lines. The Society of Critical Care Medicine has a level 1 recommendation that all central lines be placed with ultrasound. And the Agency for Healthcare Research and Quality has it as one of the top 11 evidence-based measures to decrease bad outcomes and increase patient safety by using ultrasound for central lines. Okay, fair enough. These are good guidelines. But what about ours, ACEP? Well, ACEP came out in 2016 with a clinical policy on a bunch of indications for ultrasound. And under vascular access, the primary indication is for central lines, that it should be used to first look at patency and location of the vein when placing all central lines. So ACEP has stamped it as well that we should be using ultrasound for our central lines. So I agree. It is really cool to do it blind. To have your eyes closed and shoot a free throw, or to get a subclavian vein without seeing where you're going is super cool. But the last dance is over. And the theory, guidelines, and evidence all support a new era where we can actually see what we're doing, and that's with the ultrasound probe. And that is why ultrasound IJ is the GOAT. Thank you very much.
Thank you, Dr. Thandi. I knew this was going to be a good discussion. So we are going to move on to 10 minutes to talk about this topic. Before I let Dr. Saigan and Dr. Thandi kind of duke it out, I'm going to introduce my colleague, Dr. Jaiswal. He is the Deputy Medical Director and the Associate Chief of Service at Metropolitan Hospital. Dr. Jaiswal, welcome. I'd like to start off the panel by asking you the first question. So the burning question on the chat is, we're talking about blind subclavian, we're talking about ultrasound guided IJ, but what about an ultrasound guided subclavian line? What are your thoughts in general on this topic?
I would say ultrasound guided subclavian is probably one of the least commonly performed procedures, unless you have a very good reason. And if you're unable to do it, do an IJ, you probably do an ultrasound guided femoral, then subclavian. Subclavian, because of the clavicle itself, doesn't really lend itself very well for ultrasound guided placement. The supraclavicular, maybe you could do it as an approach, but I would definitely not have it as a first, second, or even third option in terms of using ultrasound. I would still go with IJ or femoral before I would even attempt subclavian through the ultrasound.
And to throw it to Dr. Thandi and Dr. Saigan, I mean, my thoughts, and I want to hear what you guys have to say as well, are, don't our residents have to learn how to do, as Dr. Saigan said, a landmark guided line? At some point, the ultrasound machine won't be charged, it's going to break, it's not going to work, you have a trauma, there's too many people, there's not enough room. So maybe what Dr. Saigan was saying has some weight? What do you guys think?
I definitely agree. You know, so as much as I love the ultrasound guided IJ, I think doing the blind subclavian for these reasons is really important. You could be an international elective, you could be a community hospital where engineering has the ultrasound and is doing repair. You could be called down to a code or cardiac arrest in a SPART that's not your department in radiology on the floors, and they don't have ultrasound, and you might be asked to put in a line quickly. And without the ultrasound at your hands, you know, you're not gonna be able, it won't be, the blind subclavian is a great option. So I think it's important for residents to train in this and learn it. Yeah, that's kind of my take on that.
So
yeah,
then, go on, sorry.
Dr. Corrado also brought it up in the first talk, is that being dependent on technology could hurt us in certain situations. And, you know, so teaching it and learning it and finding the situations where it could be practiced is super, super important. As it being, in regards to the ultrasound guided subclavian, you know, there more and more evidence is coming out. The studies are pretty small, but since 2016, you know, they have identified approaches, and there actually is a great video on the New England Journal of Medicine, how to look at the axillary approach using an ultrasound. Anecdotally, personally, I never performed this. You know, just looking at the video, you just seeing that pleural line so close to the vessel kind of turns me off on it. But again, that's the dinosaur in me. I think it's something that with more evidence and more practice, it could become more and more of a first line procedure.
Yeah, with the ultrasound guided subclavian, I guess my little take there is, yeah, so I like the idea. They're saying it's technically a little more challenging than the ultrasound guided IJ because of the clavicle there, and that's something we're not used to. That actually the same Cochrane group that I brought up there looking at ultrasound IJ, they actually did the same review with subclavian and femoral. And interestingly, I found that the subclavian actually didn't show any statistically significant benefit with overall decreasing complications and overall success rate. So I found that interesting. But then in the same year, there was a Canadian anesthesia group that posted a review over 10 studies looking at ultrasound versus blind subclavian, and they actually did find a decrease in overall complication rate. So I agree that I think right now the literature is coming out, but it's not like well established that using the ultrasound for subclavian has that benefit.
So should we even bother with an ultrasound guided subclavian? I mean, we've got lots of ultrasound guidelines. We have a great, easy, the landmark guided subclavian, it takes 3 seconds. It's really fast once you have the technique down. So what's the utility? Dr. Jaiswal, I know you trained at Lincoln, which is a big trauma center. So what are your thoughts on this?
So, as a dinosaur myself, I can definitely say that when I was training, all my attendings, either in the emergency room or in the ICU, most of them leaned towards doing the landmark guided subclavian because that's what they were comfortable with. I have, in fact, our program director, Dr. Strugi, I know he said that he's actually never missed a landmark subclavian line, and he has missed it with the ultrasound doing an IJ. But I think it's all more also on like your preference, your training, and your how comfortable you are with that. A lot of us, when we started, ultrasound guided was not that much a big part of our curriculum, and it's not something that instinctively we used to go for. I think now it's completely changed where residents today are so much more comfortable using ultrasound for different modalities. So I think that's why it tends to get preference now. So even in our program, as you can probably attest, the first preference is going to be an ultrasound guided central line. And if you miss, you might even try the femoral ultrasound guided, and maybe in a third or fourth situation, maybe try the landmark subclavian. But I definitely, agree with Lucas in the sense that it's definitely a skill that needs to be learned, that needs to be taught, because, it's always a tool in your arsenal, and you never know when you're going to need it. So you want to make sure that when you do use it, that it actually is useful, that it actually serve the purpose of what you're trying to do. So I think we should definitely make it a point, either through simulation or in different practices, of teaching it to the residents, because that is definitely a skill that eventually will be lost, because ultrasound is only going to be more pervasive in our practice, not less. So it's not actually going to go away. So I think, as you said, depending on technology is always a bad thing. If you can't function because you don't have an ultrasound, that would not be acceptable anywhere. So definitely learn it. Use it as maybe a second or third option. That's kind of like how I approach it.
So how do we get our residents to learn it? It's kind of the same conversation that we had with the VL versus DL lecture. How do we get our residents to learn it if we're all hesitant and we're all pushing ultrasound? And I know right now I have some residents who've graduated and work locums, and they don't have ultrasound machines when you're working at these very remote locations. Actually, right. I was very surprised to hear that. So why are we all always pushing ultrasound? It's the same thing. We do need to get our residents to do subclavians. We talked about basically there's risk of infection versus risk of pneumothorax. So I know you ended with a very strong comment on that, Dr. Thandi. Dr. Saigan, what's your take on his take-home message from that?
So, I think it's important identifying the situations where it could be placed in a safe manner. That's how we're going to teach it. That's how we're going to get our residents to do it. Even though my last paper showed that body habitus had nothing to do with it, you're going to look at the landmarks, see what's a good landmark. You're going to know the contraindications, which that Thandi also brought up, the supertherapeutic INRs, the thrombocytopenic patients. You're probably going to stay away from those. But you should try and look for those situations where it's possible. It's like the airway, sometimes can be hard to predict, but at the same time, with experience, you can identify those cases so that we can pass this gift along in the right scenarios.
Dr. Saigan, do you know in the literature, I'm not sure if it came up in the papers, how many of those pneumothoraces were actually clinically significant and needed a chest tube? Are there studies that go over that? Because that obviously makes a difference.
So the 3 sites paper that we spoke about, actually, the only mechanical complications the only pneumothoraces that they brought up are grade 3 pneumothoraces that needed some intervention. And most of the studies really do identify that it's not just like this occult pneumo that gets better after 6 hours of oxygen. So yeah, so the literature is pretty good in identifying the clinically significant pneumothorax.
And just to echo with Dr. Zeigan saying, I completely agree. I think that there's some, like, we have to actively look when we could use the subclavian, vein blind. And a couple indications. One, in hypovolemic patients, because I showed the picture of the respiratory collapse, actually the subclavian is bigger. So if you have a very hypovolemic patient, that might be like an indication that maybe I should be doing the subclavian because it's going to be have less respiratory variation. And then you could argue too, if somebody already is going to get a chest tube on a side, or already maybe going to do a finger thoracostomy, that's something that's part of your practice in cardiac arrest, then your risk of pneumothorax is going to be less because you're going to be evacuating that space anyway. So I think I agree completely with Dr. Zeigan that we need to learn it and that we need to just actively look for the opportunities where we can train our residents for this.
And so I wanted to direct this question. So Dr. Jaiswal, you're the Deputy Medical Director and the Associate Chief of Service. So your goals are more departmental based, patient safety focused. We're a little bit more on the educator side and always pushing for the residents to get the best education. So some different ways that we can confirm. So let's move away from blind subclavian versus ultrasound guided subclavian. And I'm going to still talk about ultrasound with the subclavian. So technically, I can do a blind subclavian line and then confirm it with the ultrasound. Let's say it's a trauma. We got a C-collar. It's abdominal trauma, so I'm not going to place a femoral, and there's no room for my ultrasound. There's too many people. I place a blind subclavian, but I don't want to wait for the confirmatory chest X-ray. Can we just use the ultrasound to confirm it? It's not common practice. It's not standard of care. So from more of a departmental perspective, how would that look when you're looking retroactively at charts?
So, the thing is, it's all good if things go well and there's no problem and you're able to confirm with the ultrasound and everything is fine, and actually patient benefits from that early intervention and being able to use the line. The problem comes is like when something goes wrong, right? If there's a complication that develops, and no matter who reviews that whole case, and this is me putting more my admin and quality hat on, is they're going to see if there was any deviation from what is standard of care, okay? And that, whether it contributed actually to the whole situation or not, whether your ultrasound use of for subclavian and confirmation, whether that actually was even contributing to the complication of that patient, that is going to be something that you will constantly have to explain. That why, when conditions permitted, did you deviate from standard of care? Because these guidelines, that are sent out by all these different organizations, they do have some sort of meaning, and they do need to be observed and followed. They're not rules, but they're guidelines. But even if I were to move to like even a medical legal risk management point of view, again, anywhere where there is standard of deviation from of standard of care, that is going to be a problem. So it becomes harder to defend a complication in that situation.
Obviously, which is why a lot of us go on. Dr. Zeigan.
That being said, and I agree with you, when things go wrong, there is enough evidence that you could say that I'm supported by there's safety in these lines. Again, my first line is probably going to be the ultrasound guided IJ. And I don't know if the defense enough is if I cause a pneumo by practicing one, like, hey, I got to keep my skills up. It might not, the risk management department may not like that. But being in education and academia, I think it is important. Yeah, but there is evidence to make it an argument when things go wrong.
I mean, I agree. You can always make a case, but if someone asks you, Dr. Adamakos, did you follow standard of care in managing this patient who now has a severe complication? And even if it had nothing to do with you, it's actually, you're going to end up defending that whole case. So from a risk and medical legal point of view, especially that becomes important when you're practicing in remote locations where you don't have much backup, right? Because the chances of complications are potentially higher, or you have less backup and less resources. So in those cases, it's a very fine balance, because you also want to make sure that, you know, your residents are practicing safe medicine, safe for the patient and safe for their own careers as well. So, you know, as much as I support academia, and I definitely think that, you know, subclavian is something that we need to learn, and we need to use whenever we can, and encourage our attendings to do that. You have to keep in mind the bigger picture as well, because that can sometimes kind of get lost.
And I think, you know, again, the trauma patient, abdominal trauma, you're suspecting also an unstable C-spine fracture. I think it's easy to defend going to do a subclavian. Obviously, it becomes the other patients that's a little harder. Right. Now, for all the panelists on here, some questions came up in the chat. Let's say you have a crash patient, you're doing CPR on them. Maybe trauma, maybe not. What central line do you find you have the highest success, or your residents? A lot of times these are the interns that we have them do the lines for this. What central line do we think is the fastest to get during CPR? Forget IO, there's an IO, it was placed, it doesn't work. Let's just take IO out of the picture.
So I personally would probably try the subclavian on the right side, and maybe have some other people try the femoral. That probably would be like the, you know, try and attempt both sides at the same time. So that probably would be my approach.
I think for the most part, you know, the trainees are using ultrasound guided femorals now in cardiac arrests. I do think, and it is brought up by some of maybe one of my mentors, that it is an excellent area of to practice the subclavians because of the lower risk. But again, universally, I think, because of the experience, because people like that ultrasound machine and they use it more frequently, the ultrasound guided femoral lines are what they use more commonly.
Yeah, we're using blind femorals. However, I agree. I think this is a great opportunity to be using the subclavian, and I'm glad that other places are using it there. And then I would say also this might be an opportunity like for a supraclavicular approach to subclavian, because now if someone's doing CPR here and you can't access the clavicle, now you can take the supraclavicular approach. I guess one of the studies was saying the landmark approach is equally as safe, and that with ultrasound supraclavicular approach, they actually had like shorter time of procedure and higher first attempt success rate. So that might be, I think, a good indication to even start to try the supraclavicular approach during cardiac arrest.
One last question for you guys, and then we're going to move on. There's been some chatter about using manometry as a standard approach to secondary confirmation of central lines. Lots of ICUs and anesthesia colleagues are using it. I know I've never used or heard of this approach. Again, I'm ED, I'm not ICU. Do any of you have a comment on this?
So in my research of doing this, I did see some papers that spoke about this, and it was mostly in the anesthesia ICU journals. You know, you need certain tools. You need an A-line sensor to do this. I think it adds a little bit more time. I think using an ultrasound in this to confirm the guide wire placement before you dilate, like Dr. Thandi brought up in his lectures, is good enough. It should be the standard of care. The papers that I saw didn't really go into that. They went into VBG, ABG sampling, but that, I mean, that's a great future study that I'm sure is going to come down the pike.
Awesome. All right, guys, thank you. And it was really great hearing from all of you. Thank you, everyone, for joining.
Thank you.
Thank you. Thank you.
So we're actually going to take a break right now. We're right on schedule. So we're going to have a break from 10:15 to 10:30. We're going to start back up at 10:30, and we have a whole bunch of other lectures and panels to continue on our day with. Hopefully you've been enjoying what you're hearing so far. Make sure you sign up with the QR code, and we will be back at 10:30 to start the second half of our conference. Thank you, everyone. You can keep up with questions in the Q&A or the chat. We're here to answer and help. All right, guys, it's 10:30. Let's get started. Can everyone hear me? Awesome. So thank you all for attending our biannual ALL NYC conference. This is ALL NYC 18. Please, everyone who's involved, scan with your phone the QR code so we can get everyone to register. Also in the chat, we have the link for you to register if for some reason you missed this QR code. It's important for us to know how many people attend so we can better serve all of your needs. So thank you, everyone. A little shout out for everyone to vote. Early voting is open in New York, so take time. Anytime you have off, please go vote. It's very important. We are going to move on to our next evidence-based medicine discussion. We are going to talk about invasive versus non-invasive approach for resuscitation. To start us off, we are going to discuss an invasive resuscitation approach with Dr. Tiran. He is ultrasound faculty at Perelman School of Medicine. He's also the associate director at the Center for Resuscitation Science at the University of Pennsylvania, where he is currently leads the resuscitative TEE program. Dr. Tiran, we're really happy to have you, and I'd like to hear your take on this topic.
Thank you, Froso. I can't share my screen right now. I need you to enable me.
You should be good now, Felipe.
Okay, thank you. All right. Thank you very much for that introduction, Froso, and thank you to the entire committee for the invitation. This is a special day and a true honor for me. I was one of the first fellows of this very successful program, so it really fills me with pride to see how our mentors and the heads, the leaders of ALL NYC have continued this tradition in advancing this this program that is mentoring and teaching so many. I'm Felipe Tiran. I'm interested in resuscitation and how we can improve cardiac arrest outcomes. Rather than convincing you of one particular approach, what I would like to do here is to share with you my perspective. My perspective is a product of my clinical experience, of course, in an academic tertiary center, my research in this area, and the study of this field. While the quote unquote side of this debate that I got assigned in this case was to advocate for the rationale and evidence of an invasive approach in cardiac arrest, I usually don't really believe that that is the right way of thinking about arrest care in general. Yes, I do more often use invasive tools during my cardiac arrest management, including hemodynamic monitoring, TE, among other tools. But I think this is to great extent basically determined by a selection of the type of patients that we care for and the type of environment that I work at. So rather than aiming to convince you that my way is the right way, I want to give you a framework. And it is important to start by giving you my disclosures, which are relevant to this presentation. And instead of invasive or non-invasive approach, as I said, I think the question we really need to ask ourselves is, what does a patient need? What does a patient need? Well, I think this is pretty simple. The patient needs to survive. They need to be brought to life, to be resuscitated. They don't care about what tools you use. They need to have their heart return to spontaneous circulation, ROSC, ideally with a functional brain. How do we do that? As emergency physicians working in ERs, we are advanced cardiac life support. This is our playbook, our guide. But here's the first problem. The ACLS guidelines, we need to understand that they are just that, a framework, a guidebook. Resuscitation guidelines are meant to define a minimum standard of practice, but they don't really define what should be done. Unfortunately, while having a major impact in the quality of resuscitations across the board, likely responsible, I think, for the sustained improvement in impact that we saw for the first decade of the century in cardiac arrest outcomes. The guidelines have been really provider-centric as opposed to patient-centric. They have prioritized the interventions that are most convenient for us, the low-hanging fruit, so to speak. We approach every patient with the same algorithm, regardless of their physiology and regardless of their response or lack thereof to our therapies. We give them high quality CPR, we give them epinephrine and shocks when indicated. And we hope that somehow that will work. Thankfully, in the latest resuscitation guidelines that were just published this week, actually, the committee recognized in one of their key 10 home points that recognition that all cardiac arrest events are not identical is critical for optimal patient outcome, and specialized management is necessary for many conditions. I think this is a great step in the right direction towards resuscitation that is really patient-centered and not provider-centered, where we do what individual patients need rather than blindly applying one bundle for everybody. Having established this idea, I want to give you 3 key concepts to consider here. Concept number 1 is that easier is not always better. Cardiac arrest resuscitation is difficult. We need to practice and be experts at it. The fact that some of the interventions that we discuss around resuscitations are technically and logistically challenging, or they are invasive, quote unquote, should not really be an argument against if they provide valuable information that can help our patients. Cannulating someone coronaries is invasive and difficult and requires practice, but cardiologists do it all the time. And we don't just give them thrombolytics to MIs because it's challenging to do angiographies. Same with ECMO. In some centers, we are able to put a patient on ECMO during cardiac arrest because we know it's a life-saving bridge, as demonstrated by numerous studies. ECPR is invasive. It's not easy. It's difficult. It requires practice. It requires teamwork. But guess what? Sometimes it's the right thing and can make a difference between life and death. Concept number 2, we are the highest level of care for resuscitation. We can't really expect to provide the same level of care everywhere. It makes no sense to me that to think that we should manage patients in cardiac arrest the same way, regardless of our environment. Pre-hospital, ED, ICU, OR, the bar cannot be same for you, an ER doc running a code in the ED, than a paramedic running a code on the street or a healthcare provider running it in a nursing home. If the patient codes in the emergency department, we should be able to provide the highest level of care, to provide patient-centered and goal-directed resuscitation. Concept number 3, based on the available evidence, physiologic monitoring is recommended by our society guidelines. Guidelines that are endorsed by ACEP and Society of Critical Care Medicine, for instance, advocate since 2013 for an approach that includes the use of real-time monitoring in physiologic parameters during resuscitation in advanced settings like ED or ICU. And the reality is that not much has really changed in the way we resuscitate patients over the last 60 years. In fact, very little has changed. But while the way we resuscitate patients hasn't really changed, specifically our sort of one outcome improving therapy, closed chest CPR, we have really learned a fair amount of hemodynamics in resuscitation, and we can't just ignore this. We have learned that the key to obtain ROSC is to generate certain threshold of coronary perfusion pressure, or CPP, which is the most important determinant of chances of getting ROSC. This coronary perfusion pressure is what we can obtain with our invasive arterial line during cardiac arrest. And we do by subtracting the CVP from our diastolic blood pressure. And if we don't have a CVP, we can just use as a general approximate surrogate our diastolic blood pressure. Specifically, the studies led by Norman Pardis in the 90s taught us that we needed to generate a CPP of 15. And unless we do that, it's essentially impossible to get ROSC. So the ultimate goal is to achieve ROSC while perfusing the brain and the heart. All interventions that we do during resuscitation are directed to increase the chances of ROSC and neurological outcomes. And like Dr. Harry Weil said 20 years ago, running a resuscitation without knowing such physiology data is just like flying an airplane without an altimeter. Furthermore, there's been newer animal and human data that supports the physiology-guided therapy or strategy that uses individuals' patient physiology to guide resuscitation is better for outcomes. The summary table shows the described parameters, the parameters that we have to measure the effectiveness, if you will, of our resuscitation. On the top left, we have the most direct physiologic parameters that are available. Those are CPP and its surrogate, as I mentioned, the diastolic blood pressure. Coronary perfusion pressure and arterial and diastolic arterial blood pressure are the closest surrogate we have. The data has shown that both of these markers, CPP and diastolic blood pressure, are associated with improved chances of ROSC and survival outcomes. So yes, putting an arterial line during cardiac arrest and using that waveform to guide the resuscitation, aiming for a diastolic pressure target greater than 25 to 30 is an ideal indicator of our resuscitation performance. Entitled CO2, waveform capnography, is a reasonable non-invasive alternative, but as a measure of pulmonary flow rather than actual cardiac output, entitled CO2 is subject to many confounders that make it significantly less reliable than hemodynamic endpoints. So hemodynamic monitoring is preferred. And what do you guidelines say? What do our guidelines say? If you have an outline and CPP available, shoot for a goal of CPP greater than 20. If you only have an outline in place, use a diastolic blood pressure greater than 25 to 30. But that is not all we've learned. We've also learned that standard guideline-directed CPR just doesn't work very well. It's not very efficient. We know that when we do high-quality CPR, we're really only generating 20 to 30% of cardiac output. And we've learned that an important factor that may very well explain why CPR is so ineffective is that a number of radiology and clinical studies over the last 2 decades have shown us that compressing at the internipple line, as recommended by guidelines, just doesn't work for all patients. That in many patients, you're not actually compressing the left ventricle, but instead obstructing the left ventricular outflow tract or the aortic root. And it's for this reason that TE has emerged as a well-suited physiologic indicator of CPR effectiveness. As you see in this image, the key advantage of TE is that we can visualize the heart in real time doing chest compressions. And as you would expect, just like transthoracic, we can use TE also to identify those reversible pathologies. We can use it to assess the effectiveness of our interventions. And as I mentioned, we can also improve the quality of chest compressions. This is an example to prove the first point. This patient had PA arrest and was getting high quality CPR. This was the diagnosis made within the first minute of resuscitation in TE. If we don't deal with this thrombus in the right atrium leading to a massive PE, this patient is not going to achieve ROSC. How do we do TE-guided CPR? What makes TE unique is that we can obtain a plane in which we have a picture of the same vector, the same plane in which we are compressing the heart. So we can analyze compression and decompression phase and look at whether the aortic valve is actually being open during the compression phase, as opposed to being occluded, as in this example below. This is an example of that happening during cardiac arrest. Ongoing CPR and compressions are obstructing the left ventricular outflow tract. This is an example of the same patient, first with compressions over the left ventricular outflow tract, and now the same patient having optimized the area of maximum compression. There's another patient with a TE showing specifically the aortic root. If you play this frame by frame, you'll see that at no point throughout this clip, there is opening of that aortic valve. So there's no forward flow. And even if you think that that doesn't make sense, you have to accept that in an image like this one, that image is now there. So how common is this problem? Well, according to prospective data from our group, this is actually a fairly common problem. Over 53% of patients had compression of the aortic root or LVOT. Another study, recent study from a European group showed that not only this actually occurs frequently, but that when this happens, there is, in patients that have their LVOT open, they have higher chances of survival at 24 hours. This is the first study actually linking LVOT compression and survival, and further supports the theory behind guiding resuscitation with TE. And this data has really come to confirm previous studies performed in animals, where the idea that we can generate better hemodynamics with TE-guided CPR is in fact true, and that we can, in fact, we cannot obtain ROSC if we don't reach that target of CPP, as demonstrated back in the 90s. And another study recently showed that also, as we would expect, because it's easier to obtain TE images compared to TTE, there is a potential to also decrease the duration of pauses, further improving the effectiveness of CPR in the chest compression fraction. Last but not least, a lot of people raises the concern that using an invasive tool such as TE can distract the team or take attention away from key interventions during the resuscitation. But this video shows you how much, or how little, I should say, TE interferes with resuscitation. After obtaining the views that are needed, the probe can be literally just hung in place like this throughout the resuscitation. If you're interested in learning more of the evidence and the details, there's a great review by our group in JACC last month, covering this in a more comprehensive fashion. So the take home for me is that hemodynamic directed resuscitation not only is feasible, but could lead to better outcomes, and currently is recommended by our society guidelines. I think we can no longer accept a treatment algorithm that treats all cardiac arrest patients the same way. I think a patient-centric personalized medicine approach, it is the future. But as said in this editorial, our patients need resuscitation now. Resuscitation scientists and rescuers alike should be feeling the pressure. Thank you.
Awesome. Thank you, Dr. Turan. I'm going to move on to a different lecturer right now. We are going to be talking about a completely different approach, a little bit different, more of a non-invasive resuscitation approach. We're going to hear the pros and cons, and to introduce this lecture, we're going to have Dr. Rolston. He's the Director of Critical Care and Emergency Department of, at Hofstra Northwell Medical Center. He is also a trauma SICU intensivist, so he's dual trained. His research focuses on improving resuscitation outcomes through evidence-based performance and bedside ultrasound use. So I think we're going to have a really interesting perspective here. And take it away, Dr. Rolston.
All right, 1 second, getting it pulled up. All right, Frosso, thank you so much for having me, and thanks everyone for listening to my talk. So, I was asked to talk about why a less invasive approach is better, but really today I want to talk about why it's faster and more effective for cardiac arrest management. So a quick disclosure, some of the research you're going to hear from today has been funded by a Zoll Foundation grant. And you just heard from Felipe Terran, who's one of the most innovative researchers and educators in resuscitation. But what he probably didn't tell you about is some of the cons of TEE and arterial lines. So first off, for a TEE, patients need to be intubated. You can't use a supraglottic device. And as we've seen in recent research that's come out in the past couple of years, especially in out-of-hospital cardiac arrest, a supraglottic device could be more beneficial than intubating a patient in cardiac arrest. I worked in a CT-ICU for 3 years, and even though I was placing TEEs pretty regularly, placement is not that easy. It can be difficult to get into the esophagus at times. So if you're not a person who's doing this frequently, and you're only doing it every 3 to 6 months, that's not going to be enough. You need to be like Felipe. You need to do deliberate practice if you want to use TEE in cardiac arrest. Now, we are using A-lines at North Shore, but we found that it takes time to set up. And placement's not easy. Seeing your needle with chest compressions ongoing is hard. Lots of our patients have vascular disease who have cardiac arrest, and it can be hard to thread a wire. And then, the reason you're putting it in is to interpret a diastolic blood pressure, as Felipe just told you. But interpreting that can be really hard in cardiac arrest, and I'm going to show you why. But the big reason these TEE and A-lines are hard in cardiac arrest is because they take time. And unfortunately, time is your enemy in cardiac arrest. So every intervention you do needs to provide the most benefit in the least amount of time. And how much time do you have? This huge study of over 280,000 bystander witness cardiac arrest out of Japan says you have about 45 minutes to get ROSC. And they really had no neurologically intact survivors after 45 minutes. At our hospital, the median time from EMS dispatch to ED arrival is 41 minutes. And 75% of all the cardiac arrests that we take care of are out of hospital cardiac arrests. That's not leaving a lot of time for TEE and A-lines to manage our cardiac arrest patients. The one caveat to this might be in ECMO patients. So in Minnesota, they're seeing pretty incredible numbers, 20% survival up to 90 minutes. But this is for a very select portion of patients who are young and generally have VF and VT arrest. So, and the thing that's really benefiting them is the ECMO. It's not the A-lines and the TEE. So what I'm telling you today, I've kind of learned from watching videos of cardiac arrest resuscitations for the past 3 years. And that's that the more interventions we do, the more complicated it is and the more time it takes. And while we all wish that our resuscitation teams looked like this, the fact is that they don't. The median time to interventions in cardiac arrest at our hospital, time to a rhythm, 2 minutes and 34 seconds. The time to first defibrillation, 5 minutes and 29 seconds. The time to intubate, 6 minutes and 8 seconds. And the time from start to finish of placing a mechanical CPR device is 70 seconds. We've even started looking at A-lines within the past year, and we're not always successful with placing an A-line. We're successful about 67% of the time. And from the time we start trying to place it to the time we finish is 5 minutes and 4 seconds, and that doesn't include setup at all. So, there's a reason why when I first did ACLS back in 2006, it looked like it did on the left, and now it looks like it does on the right. Simplicity is better in complex resuscitations like cardiac arrest. It's easier and leads to better outcomes. And the more videos I watch, the more convinced I become of the fact that unlike a golden hour in trauma, we really have to focus on those first 10 minutes in cardiac arrest care to improve outcomes for our patients. So what I'm going to try to convince you of today is that a non-invasive approach to optimize early goal-directed CPR using modalities that you use every day is more beneficial. And this starts with a better way to do pulse checks. So we can't just be using our finger on the pulse to see if we have a pulse anymore. We need to start using our ultrasound skills. And this involves placing a high frequency linear probe over the either femoral or carotid artery and turning on the Doppler. And on the left, you can see pretty clearly there's no pulse. On the right, you can see a pulse. Just some anatomy reminders. The carotid is going to be deep and medial to the IJ. And in the femoral area, it's going to be lateral to the vein. Remember, nerve, artery, vein, empty space lymphatics as you move lateral to medial. So I'm going to show you an image of what CPR Doppler ultrasound looks like with CPR ongoing. So here we can see, as you're compressing the chest, you get bidirectional flow. There's flow moving away from the patient, away from the probe, and then there's flow moving back towards the patient. So this is causing kind of a sloshing of blood back and forth in cardiac arrest. And this leads to those problems with interpreting a diastolic blood pressure with CPR ongoing. You want to measure at point B, which is right before the chest compression. That's where you want to measure your diastolic blood pressure, but the machine is going to measure at point A automatically. So you need to know to change that cursor if you're using an A-line. Scott Weingart has a great talk on this for anyone who wants more information. So this was that same patient at the next pulse check, and the team didn't feel a pulse here, but there clearly is a pulse. Now, some people may say this is pseudo PEA. This probably isn't adequately perfusing blood pressure. But maybe this tells you, hey, we can start a norepi drip on this person. This person maybe needs more fluids. Maybe they need blood. We can try to do interventions to improve the blood pressure in this patient. And luckily, recently, there's been some research that's come out. Just 2 weeks ago in Resuscitation, a paper was published looking at the success of carotid Doppler for detecting a pulse in patients who are undergoing cardiac surgery. And as they progress to cardiac standstill with an A-line in place, the sensitivity, specificity, and accuracy of carotid Doppler were all over 90%. Even if the patient had a blood pressure that was less than 70, the sensitivity for detecting a pulse was 83%, which is much better than your finger. I need to give a shout out to one of my coworkers, Allie Cohen, whose research is looking at this exact topic, the use of Doppler ultrasound for pulse checks and cardiac arrest. She won a Young Investigator Award at the Resuscitation Science Symposium, which is happening in 2 weeks. It's a cheap conference, it's only $50. I suggest everyone attends if you have time. But what Allie's found, and she's going to present updated data on this, is that if you have a pulse, your sensitivity with Doppler ultrasound is better than manual palpation. The specificity, if you don't have a pulse, is better, and the accuracy overall of Doppler ultrasound is better than manual palpation in comparison to a gold standard of an A-line. Moving on to transthoracic echo. A couple of years ago, a group out of Highland came up with this cardiac arrest and sonographic assessment. And this has 3 components protocol. At the first pulse check, you look for cardiac tamponade. Second one, you look for right heart strain. And the third one, you look for cardiac activity. Using this protocol, decreased compression interruptions from 19.8 seconds to 15.8 seconds. And if you put the probe on the chest before pausing your chest compressions, you were 3.1 seconds faster. At our hospital, we're using things like a countdown, 10, 9, 8, to try to limit the compression pauses. And we're also saving a clip. So hopefully you can capture all 3 components of that exam with 1 clip and review it during chest compressions before the next pause. And where is the best location to look with transthoracic echo? We've recently started looking at this as well. I was always taught that you should look at the subxiphoid area, but our success with subxiphoid is not good. 55% successful at visualization of the heart, whereas we're 92% successful with parasternal and 100% with apical. Granted, that was 2 patients. We're using a Lucas in all of our patients, so this is a little bit different. We're not using manual CPR. It can be harder with manual CPR to get a parasternal view. And finally, Felipe talked about this, but the AHA recommendations from 1 week ago say that you should still do chest compressions the lower half of the sternum. But here's an image showing a patient with the Lucas ongoing over the lower half of the sternum. And what we see is that RV is compressing really well, but that LV is not really moving. And we can see during the pause, they're still in cardiac arrest. So what we've started to do is use TTE to change the location of your CPR. We've been able to visualize this frequently, and it doesn't always require a TEE to do. So instead of doing CPR here in the lower half of your sternum, maybe you should move your CPR over to the left ventricle to get better LV compression. So in summary, team speed is critical in your cardiac arrest care. You should use Doppler ultrasound for your pulse checks. And if you're using transthoracic cardiac arrest, you should try a parasternal approach first and move compressions if you realize they're not being effective with transthoracic echo. That's my daughter, and thank you so much, everyone, for having me. I look forward to the discussion.
Thanks, Dr. Ralston. That was a really great talk. So we're going to move on to a 10-minute panel. If anyone has any questions or any chat points, you can put them in the chat or the Q&A and we'll try to get to them. But first, I would like to introduce Dr. Kerbedin. She is my old friend and a leader in this field. She's a medical student clerkship director and ultrasound faculty at Maimonides Medical Center. She's as well a lead collaborator on a multi-study TEE study with Sanford. She is the head at MIMO of a grant study comparing TTE versus TEE use in cardiac arrest. She also has the interesting perspective of having worked in small community settings where she's not with residents and doesn't have a million people helping her out. So she's going to have really great insight on this topic. So Dr. Kerbedin, thank you for joining us.
Hi, thank you so much for having me, and I'm honored to be here with Dr. Turan and Dr. Olson.
So we figured for this topic for the panel, let's start off with a case and want to take everyone's approach on what the best way to manage this is. So let's say you're at a big academic center. Here in New York, you have residents, you have lots of people around, and you have an in-hospital arrest. EMS brought a patient, they don't have much information, they were kind of breathing and had an organized rhythm when they came in, and then all of a sudden they're unresponsive. You have no real information on the patient, and it looks like they're in PEA arrest. Organized rhythm on the monitor, but you don't feel a pulse. What is your best approach, Dr. Kerbedin? What do you suggest based off the information we heard from Dr. Rolston, from Dr. Turan, and based on your experience?
So I would say that age would play a large role in how I would actually address this as well. If I'm in a large academic center, like you said, I would, and it sounds like it's a witnessed cardiac arrest. This is a patient that I would assume has it's a young, healthy male, let's say, with a healthy heart with no past medical history. Therefore, I would be pretty aggressive. I'd throw everything but the kitchen sink at this patient, hopefully if I have these resources. So I'd probably address it in a stepwise approach, knowing that my main tools here would probably be a VBG and an ultrasound. So being in a large academic center, I'm assuming I have TTE and TEE. I would then obviously secure my airway first, most importantly. Hopefully that is something that we can do in order to use the TEE, as Dr. Rolston was actually saying. I'd make sure that the patient was hooked up to end-tidal because that's a good measure of our cardiac output. Hooked on the monitor. Hopefully I have a Lucas device, place them on that to expand on my resources. Continue ACLS, have a nurse prep an A-line. Like they said, that actually takes time. So making sure that that's happening while somebody else is probably placing a FEM art line. I'd also simultaneously have somebody doing a transthoracic echo as per the CASA protocol that Dr. Rolston spoke about, looking for reversible causes. If I'm unable to obtain good views or I'm finding that I'm increasing my time without chest compressions, I'm going to move forward to TEE. The studies out there in out-of-hospital cardiac arrest and ICUs are showing and support the use of TEE, that it has diagnostic, therapeutic, or prognostic clinical impact. To the point where it can actually aid in diagnosis in some of the studies, 78% of the time, and have therapeutic impact 67% of the time. So first off, in the TEE, what I would be doing is, especially in this patient, looking for signs of obstruction, starting with cardiac tamponade. I just want to stop for 1 second. Did you say that the patient had no pulse?
Can't feel a pulse.
So, like I said, I would start looking for signs of obstruction, starting with cardiac tamponade. Why cardiac tamponade? Because it's the cause of PA arrest in about 4 to 15% of cases. And actually identifying tamponade will significantly affect the chance of survival of the hospital discharge. It can actually be, which is around like 15%, much higher than the other causes of PA arrest. Next, I look for signs of right heart strain, which is a little bit of a tricky thing. So maybe possibly also add in DVT ultrasounds bilaterally, further to like solidify my clinical suspicion of a PE in order to consider using thrombolytics. Next, cardiac wall motion abnormalities like wall, valve ruptures, thrombi, pseudo-PEA, which would be really important and change my management, hypovolemia, and do a lung sweep to look for pneumothoraces. Basically, I'd be looking for all of the reversible causes that we can address to increase the chance of ROSC. Next, what about Dr. Turan was talking about is that TE has actually become instrumental in guiding chest compressions. His study citing that 53% of the time we're over the LVOT and aortic root. So there's also one of the first studies that came out a while ago showed that we're only over the LV 20% of the time. So hopefully by optimizing positioning, we can lead to better hemodynamic parameters, and that may lead to better outcomes. I'd use that along with the diastolic blood pressure, hopefully if I'm using it correctly. Lastly, like they were talking about, if this large academic center had ECMO, there's very few hospitals have ED ECMO. I would consider that. We can use the TEE to help with cannulation, and we can initiate ECMO, hopefully to bridge these patients to reversible causes, such as like the cath lab.
Sounds like a
guys?
good combined approach. I want to, before I kind of hear from Dr. Rolston and Dr. Turan, what do you guys suggest for people who, number one, don't have a TEE? And number two, let's say they have ultrasound, but they're saying, look, I can't do ultrasound guided CPR. It's hard to find a window. I'm not ultrasound trained like all of you are. So what would be your kind of advice for someone who doesn't have all the fancy equipment and maybe isn't as comfortable with ultrasound?
So, I can lead off with this one, but, if you're not comfortable using ultrasound, I think that's okay. That's part of being an ER doctor. But, you can use end-tidal CO2, as Felipe mentioned, to try to guide your resuscitation to see how effective your chest compressions are. As we've mentioned here, I think eventually we're going to be moving that chest compression location from the lower sternum over to the left. So if you find you're not getting ROSC, try moving your chest compression location just empirically. I think just practicing good care, getting a good early rhythm recognition, finding out if you're in VF and this patient needs to be shocked is one of the most important things that we do. And it's one of the things that we find the biggest delays to when we look at these videos. So I think just focusing on some of the basics is still really important to taking good care of these patients.
And to kind of go off of that question, let's say you're at a community hospital. You don't have residents. You don't have a lot of people and you don't have a Lucas device. How do you go forward in optimizing your resuscitation? What would be like the most important steps first to do, let's say, if you're only one person doing these more advanced procedures?
I can take the lead on this one, but I'm gonna actually just add a piece of my answer to the previous question. And I'm just going to say that if you feel uncomfortable with ultrasound and you're an ER doctor and you're running resuscitations, then we have a problem, and you should probably not be running resuscitations and perhaps not be a doctor. And so I think that should be the north. That person should get appropriately trained, because to me, it's like being an ER doctor and not being able to intubate in 2020. And there's lots of questions in the chat regarding what to do if you don't have TE. And I just want to reply kind of generally saying that the situation of not having TE is at this point the most common situation across the board. And so what people should do if they don't have TE is to use what they have, and what they have is hopefully TTE. I have a different opinion regarding actually the role and the ability of TTE to guide the area of compression and the location in resuscitation. And that is because, as we've seen in many clips, the images that we generate with TTE, because of the angle in which we're generating those images, are not actually representative of that interposterior plane in which we're compressing the heart. So very often, I think I see people interpret, and what I think is misinterpret, the images from TTE when they see that the image intermittently goes in and out of view, essentially, and they interpret that as lack of compression. And I think what's happening is simply that the image is not an informative image of that shortening in the interposterior plane. To your question of community hospital, I haven't practiced in a setting like the one that you're describing. And so I'm going to start by disclosing that I don't have personal experience of practicing in an environment where I don't have the support that I have right now of multiple providers, often too many providers to run a resuscitation. But I would say that just intuitively, what I think I would do in that case is to stick to the basics and the fundamentals. And the fundamentals involve recognizing arrest. So whether it's with Doppler, whether it's with an ALN, whatever you have, you need to be able to be as certain as possible that the patient has a pulse or the patient does not have a pulse, and to identify when the patient returns to spontaneous circulation. I think ultrasound and TTE or TE should also be part of standard care in community hospitals. I don't see why we need to restrict that. And so it is my expectation that community hospitals and non-academic practices should have and should be using ultrasound and echocardiography to run the resuscitations as well.
So I just want to, Tom Pereira is yelling at me on the chat, so I need to respond. I honestly think, obviously I just gave an entire talk about ultrasound. I think it's important for people to know how to use an ultrasound, but, the truth is the evidence has never shown improvement in neurologically intact survival with the use of ultrasound and cardiac arrest. Now, hopefully Felipe and I and Ali Cohen and Jeanette will, finally show an improvement, but that has not been proven so far. So I don't think you can say to a community doc that it's, you have to be, you're doing the wrong thing if you don't have ultrasound. It's not proven yet.
I do agree that I wanted to echo what Felipe said. Like, I do think that most of these hospitals should have an ultrasound, right? Most residents graduate where they are able to perform ultrasound, they're credentialed in ultrasound. I did work at a community setting, and we were lucky and fortunate enough to have an ultrasound, but we didn't have much else. I was the only doctor. I had limited nurses. And so really my main goal was kind of, how can I use this ultrasound and like a VBG to figure out what's going on with these patients and really to stabilize that patient. Like, we weren't a STEMI center. So if it was a STEMI, my thought was, how do I stabilize this patient? Maybe give them thrombolytics and transfer them. So that would really be my main thing, like give them the standard of care, giving, ACLS, and I'd be using like end-tidal CO2, non-invasive blood pressure cuff, because things like you guys are talking about, like an A-line, is kind of like out of the question at a community setting, where you're kind of the only doctor and a nurse is going to be standing there prepping an A-line for a prolonged period of time. And who's going to be putting it in? Somebody has to secure the airway, then throw the ultrasound on. So honestly, there are some studies out there, especially in like the septic patients and ICUs, that show that non-invasive blood pressure cuff with probably end-tidal CO2 will suffice. And I'm happy with that. So I'd use those tools and just standard ACLS protocol and stabilize the patient and transfer to somewhere that may be able to manage them properly.
Awesome. That was a great discussion, guys. Thank you. That's all the time we have for the panel. I think those were two great talks and a really great panel discussion talking about the different ways that we can do better at resuscitating our patients. So next up, I just want to give another plug out. People have been asking for the link. The link for registration has been posted a couple times in the chat. Otherwise, I'm giving you a second to use your phones and scan the QR code. And we are going to move on to another controversial topic. We're going to move on to chest pain right now. We're going to hear 3 different lectures, and they're actually going to be from our current ALL NYC fellows. We're going to talk about a do-nothing approach versus getting a stress test versus doing a CCTA for low-risk chest pain patients. This is a little more of our bread and butter in emergency medicine. So we're going to start off with a do-nothing approach for low-risk chest pain, and this is going to be from Dr. Grossman. He is the education chief at Maimonides Medical Center. He is our ALL NYC fellow, and I'm excited to hear your talk. Thank you.
Thank you so much. Hey everyone, I'm Duncan. I'm one of the ALL NYC fellows, and I am super stoked to kick off the topic of low-risk chest pain, but not just low-risk chest pain, but what to do with low-risk chest pain. So I want you to imagine you're in your emergency room and your attending turns to you and says, I want you to go see this patient. Get up off your chair, you walk over, and this is not unlike 100, 1,000 other patients that you've seen before. I want to introduce you to Miss D. Super nice lady. She's 52 years old. She has a couple comorbidities. She's got some hypertension. She's got some hypolipidemia. And she's coming in and she's complaining to you of stabbing chest pain. And it's not a super concerning story. So it is on the left side. It comes and goes, but it's not exertional. It's sort of spontaneous. Every couple minutes it comes on, it goes away. She doesn't have any nausea or vomiting. She's not sweating. She's not complaining of any shortness of breath. So she's going to get an EKG. She's going to get a troponin. She's going to get a chest x-ray. And then what? What are you going to do with this patient? So before I try to convince everyone here to just send Miss D home, we all need to be on the same page and agree when we're talking about low risk chest pain, what we mean by low risk. So if people start quoting like Timmy and Grace to you, it's like sort of old school. The emergency medicine community has really settled on the heart score at this point. And I know everyone knows this. Just to recap, keep us all on the same page, you get different points for different parts of the heart score, right? So H addresses your history, E addresses your EKG. You get further risk stratified based on your age and your number of risk factors. And then finally, last, certainly not least, your troponin level. So you take all of these points in the score and you add them up. And if you get 3 or less, you're considered low risk, which means you have a 1.7% chance of badness, we need to qualify this a little bit further. So 1.7% chance of something called MACE. This is a very famous number and a very famous metric. So this is major adverse cardiac events. And so this is what we're looking for when we're deciding if the patient can go home or not. So some of these things are what you would expect, right? So a major adverse cardiac event is having a heart attack or is dying, but it also includes a couple of provider-driven interventions that I would call into question. So one of them is getting a CABG and another is getting PCI. So that means if you came into the emergency room complaining of chest pain, and 29 days later, your cardiologist caths you and puts a stent in your coronary artery, you've had an adverse cardiac event. And so I wonder if there's another metric we could use, something maybe more clinically relevant when we're trying to stratify these patients. We could even call it CRACE. You could call it clinically relevant adverse cardiac events that we're searching for. These would include things like STEMI that needs to go to the cath lab. Death, I think, also should be on there. And how about forgetting the provider-based interventions? How about any sort of cardiac or respiratory arrest or any sort of fatal life-threatening arrhythmia? Well, lucky for us, a group of researchers came together and looked at exactly this question. This was a few years ago, and they published this study. It's called The Risk for Clinically Relevant Adverse Cardiac Events in Patients with Chest Pain Who Were Admitted to the Hospital. So not even low-risk chest pain. This is all patients with chest pain admitted to the hospital, and they were looking at CRACE. It was done over 5 years at 3 emergency departments, and they looked at all of the adults who were admitted with chest pain, and they said, okay, of all of these adults admitted with chest pain, let's gather up all the ones who never made troponin, 2 negative troponins. And they had 11,000 of these patients. And I just want you to think in your head what percentage of people you think ended up having STEMI, death, arrest, or arrhythmia. So 0.18%, an order of magnitude less than our MACE number that we're always searching after. And this group went even a step further. So they said, okay, 20 out of 11,000, pretty good. What about the people that we would have sent home from the emergency department? What about people who not only didn't make troponin, but had normal vitals and a normal EKG? So believe it or not, still 7,000 of these patients were admitted to the hospital, which is like mind-boggling to me. And just imagine in your head how many of these 7,000 patients with normal vitals, a normal EKG, and 2 negative troponins, how many of them had CRACE? There were so few of them that they were actually able to talk about each individual patient in the study and why they died. Okay, I can hear your judgments through the Zoom. I get it, you guys are like, Duncan, I'm not gonna change my entire practice pattern based on one study you like kind of glanced over while I was half asleep on Zoom and half Amazon shopping. First of all, that's rude. Second of all, I get it. That's fair. This is not, the penultimate study. There are issues with it. It's retrospective. It's a chart review, and it was for really short-term outcomes. But I think this argument successfully makes successfully makes the argument that admitting patients like this doesn't reduce the chances of them having bad things happen to them. But I think what you can come back at me and say is, Duncan, you spent the first several minutes of this presentation talking about the heart score and MACE. Isn't that what I should be looking for? That is the standard of care. So if my patient has a 1.7% chance of MACE, I want to lessen that. I want to, send them to the observation unit for stress or further imaging to prevent them having an MI. And I was on board with you, but unfortunately, that's just not true. We're not lessening MACE like that. So for those of you like me who thought more testing was going to prevent MACE, in the same year, in the same journal, a group came together and they published this study with a very long title, which basically says, we're going to compare people in the emergency department with chest pain who had additional testing and who didn't have testing and just went home. And we're going to see how many of them had an MI within 190 days, so 6 months. Huge numbers here. 420,000 people, and they looked back at all of their charts, anyone who was diagnosed with chest pain, and they ended up splitting them into 2 groups. So this group on the left had further testing. They had stress test, they had coronary CTA, and they had perfusion studies. And this group on the right, diddly, they didn't have anything, and they compared their rate of MI. So this was the rate of MI if you had further testing from the emergency department. And this was the rate of MI if you didn't have further testing. So there's no difference. We're not preventing MIs within 6 months. But what we are doing is that group on the left, a lot of the different subgroups in there ended up having further additional testing within that time frame, which is not benign, right? Costs more for the trips to the hospital, hanging out around COVID patients. So I hope this was helpful, brief but helpful. If you're going to consider 2 points from this presentation, I just want to give you these 2 things to dwell on. So first, is MACE a flawed measurement? You know, are we focused on provider-driven interventions for these patients when really we should be looking at the clinically relevant adverse cardiac events for these patients? What exactly are we hunting for? And the second thing I would ask you to ponder is, based on that second enormous study, is consider the position that more testing doesn't lead to fewer MIs, but it does lead to further testing. So if you're sending your low-risk patient to the observation unit, just ask yourself, what's your goal for that patient? And that really brings us back to Miss D. 52, a couple of comorbidities, kind of not super concerning story. So what are we going to do with Miss D? So this is how her ED course plays out. Her vital signs are normal. You do an exam, it's fine. She gets 2 negative troponins and her EKG is normal. And I would say unequivocally, you can send Miss D home. I'm not saying she shouldn't follow up with her cardiologist, but I am saying that we shouldn't be sending this patient from the department for more testing. But Joe and Francie are going to pose a couple of alternative pathways for Miss D. So Joe's going to talk about stress tests for Miss D, and Francie's going to tell you about how CTA could be beneficial for this patient. Thank you guys very much.
Awesome. That was really great, Dr. Grossman. Thank you. So we are going to listen to Dr. Offenbacher's approach. He's going to be covering stress tests for low-risk chest pain. He is senior resident at Jacobi Montefiore Emergency Medicine Residency and one of our ALL NYC fellows. So take it off, Joseph.
So good morning, everybody, and thank you, Duncan. My name is Joe, and today I'm going to speak with you a little bit about the role of EKG stress testing and the evaluation of low-risk chest pain in the emergency department. So I have 3 main goals for this morning. The first is to suggest that the one test or one diagnostic approach fits all mentality is not necessarily the best paradigm when considering low-risk chest pain in the ED. The second is to try and convince you that the clinical question you as the physician are asking actually matters, and specifically that the question as to the patient's coronary status is a meaningful question to ask in the ED. And third, that EKG stress testing is a safe and effective way to look at the question mentioned above. So, when considering any question in medicine, it's important to start with the clinical fundamentals. Ischemia to the heart can manifest in a wide clinical spectrum, with a major tipping point that we will discuss. ACS can range from being completely painless to experiencing pain at predictable intervals, let's say at 1 o'clock on a Sunday afternoon, to the classic clinical presentation of I have acute onset left-sided chest pain radiating to the arm with nausea, vomiting, and diaphoresis. Importantly, this clinical spectrum actually reflects variables in underlying pathophysiology of the diseased coronary artery, from progressive luminal narrowing with intermittent subendocardial ischemia, secondary to developing atherosclerosis, and culminating in complete luminal occlusion and full myocardial ischemia, secondary to plaque rupture. With such a broad underlying pathophysiologic process, it makes sense that answering these questions would need, or at least benefit from, different diagnostic modalities. If you are asking, did my patient, did Ms. D, suffer from acute coronary vascular catastrophe such as an MI? This might be answered on the one end of the spectrum by a rule out of 2 troponins, or ruled in with emergent intervention and evaluation. In contrast, worsening ischemia secondary to progressing luminal compromise might be better evaluated with other modalities, and then may warrant other approaches to intervention and management. So when discussing low-risk chest pain, we could make the argument that we're not simply looking to rule out a STEMI or other cardiovascular catastrophe, but looking for clinical manifestations of underlying atherosclerosis is meaningful in the ED context. In effect, asking the question, is our patient's coronary physiology suitable to maintain adequate oxygen supply if we increase demand and stress on their heart? If our patient's underlying coronary physiology cannot supply adequate perfusion, with increased myocardial work and demand, then we may have uncovered a very significant disease process that may warrant further intervention and subsequent management. So with this underlying scientific understanding, a bit of history is also important. Roughly a century and a half ago, electrophysiology is born. Within a few decades, normal and abnormal electrophysiological patterns are recognized to reflect underlying cardiovascular disease processes. Ultimately, we learn that under stress, cardiac function can be assessed by a variety of different modalities, and that these findings can serve as reasonable diagnostic surrogates for indirectly assessing our patient's underlying cardiovascular status. So shifting gears very slightly to their literature, the question of the evaluation of low-risk chest pain in the ED has fascinated the ED physicians for the better part of 2 decades. Approaches have evolved with the advent of new diagnostic modalities and tools, but at the core, management strategies have always been centered around exercise stress testing, which has been shown to be safe and effective for considering the patient's underlying coronary health. So the first major study was done in 1993 by Kearns, which was a prospective non-randomized study looking at very narrow inclusion criteria, specifically looking at low-risk chest pain. Their initial findings of patients with negative treadmill stress tests showed that at the 6 months follow-up, none had evidence of coronary artery disease, none had had a major MI, and none had experienced sudden cardiac death. They were able to conclude, therefore, that the exam itself was safe, efficient, cost-effective, and practical. They ultimately surmised that cardiac stress testing is a useful aid for clinical decision-making and may help to prevent unnecessary hospital admissions. By 1998, Kirk and Amsterdam followed this up with another much larger prospective study, 212 patients. Their findings showed that 125 of these patients had a normal treadmill stress test. None of those patients that experienced the stress test had an adverse effect, and that at the 30-day follow-up, there were no adverse cardiac events in the negative group. They again concluded that this test was safe and highly utile. And in 2002, Amsterdam and Kirk again looked at one of the largest cohorts of these patients, looking at low-risk chest pain in the ED. They looked at 1,000 patients. 64% of these patients had negative stress tests, and 13% of these patients had positive stress tests. At the 30-day follow-up, in the negative stress test group, only 1 patient had a non-Q wave MI, whereas in the positive group, 4 patients had had a non-Q wave MI, and 7 had required revascularization. They therefore concluded that the immediate exercise stress testing of patients who presented to the ED with chest pain and evidence of low clinical risk was safe and accurate for determining those who would require admission and those who could be discharged for further outpatient evaluation. So by way of an analogy, in football, as in medicine, the specific question you are asking is what matters the most. How many games will my team need to play in order to assess if they have a chance of winning the Super Bowl? Well, that all depends on the specific team you are asking about. For some teams, it only takes 2 games into the regular season to know that they have no chances of making it to the Super Bowl. You can basically 2-trope those teams out. On the other hand, some teams will really need to go through the stress of an entire season before anybody can draw any meaningful conclusions. So let's just say that I managed to convince you that the one approach is better than another paradigm is not necessarily the best way to look at the question of low-risk chest pain in the ED. That I was able to convince you that there is value in assessing the coronary vascular status of even low-risk chest pain patients in your ED, and that EKG stress testing is a safe and reasonably effective clinical modality for addressing this question. Always remember that there is no such thing as reverting to the automatic pilot of clinical algorithms or prescribed patient workups. No matter how many studies declare a test safe, consider the underlying EKG morphology at the background of all of the slides that have been shown. If you send a patient with this easily could be seeming benign EKG for an exercise stress test, let's just say that it may not remain a very benign stress test for very long. So in summary, when evaluating low-risk chest pain in the ED, clinicians must thoughtfully combine a thorough history and clinical exam with appropriate diagnostic adjuncts chosen to answer the specific question that you are looking for at the time. Thanks so much.
Thank you, Joseph, for that perspective. We're going to move on to our last talk of this EBM kind of discussion. We're going to be discussing the utility of CCTA for low-risk chest pain. I'd like to introduce Dr. Rusnak. She is the education chief at Mount Sinai Morningside West, and she's going to be leading off this discussion. Thank you, Dr. Brusnick. We'll just have you unmute, and then I think you're good to go.
Okay, perfect. So hello, everyone. I'm Frances, one of the ALL NYC Fellows, third-year resident at Mount Sinai Morningside West, proud resident there. For this next part, I'm discussing coronary CTA for the evaluation of low-risk chest pain, and I'm going to be using that same definition of low risk that Duncan described earlier. So we may not all be familiar with coronary CTA and its place in the workup of chest pain, so I'm going to take some time and go over some basics. It's also known as CCTA and uses at least a 64-slice CT imaging to provide an anatomical evaluation of coronary artery stenosis. The negative predictive value of coronary CTA is 100%, as determined by a 2009 study called Rule Out Myocardial Infarction using computer-assisted tomography. So CCTA is often used in the workup of patients with low and intermediate risk of coronary artery disease, which is usually determined by things like the heart score. But a lot of the studies that I've done in research for this talk really group low and intermediate risk patients together. So there are a few nuances that go into the logistics of ordering and performing a coronary CTA for your patients. Where I work, this is done sort of outside the ED, so you can't get it in the ED scanner there. Patients have to travel up to a different floor and get it in the radiology department. And it's also only available certain times of the day and certain times of the week. So in order to get adequate images, patients' heart rates must be below 70. To achieve this, they're given beta blockers, either oral or IV. And if those are contraindicated, then possibly calcium channel blockers. Sublingual nitro is also sometimes given to help better visualize the arteries. Their vitals then have to be monitored throughout, and a radiologist who has subspecialty training in cardiovascular imaging will interpret the study. The most important question to ask yourself is this even available in my emergency department? Can it be ordered and done through the OBS unit, or is this something more inpatient, or do I just have to completely refer out for it? Of course, this imaging is contraindicated or avoided in pregnant patients, those with contrast allergies, severe AKI or CKD where you have some concerns. It's also contraindicated in patients who can't receive those beta blockers, for example, active asthma, maybe a borderline blood pressure. Patients cannot have a persistent tachycardia, and they cannot exceed the maximum weight of a CAT scanner, of course. Then there are certain times where coronary CTA is not the most appropriate test since we have other ways of working up chest pain. Consider alternate testing if patients have concerns about their additional radiation exposure. Elderly patients, say those over 80 or so, who may have extensive calcification artifact that's going to limit evaluation of stenosis. So then you might want to proceed down another route. And then you also have patients who have known moderate or severe coronary artery disease. These patients won't benefit from CCTA imaging and instead should probably just move on to a cath. So when you get the report, CCTA is going to provide you with a percentage luminal diameter narrowing of the left coronary artery, right coronary artery, LAD, circumflex, and their first order branches. So if you get a report of normal coronary arteries, that's great. These patients can be safely discharged from the emergency department. But you may have a report of mild, less than 50% stenosis, moderate 50 to 69, or severe, greater than 70% stenosis. Those with mild disease can still be safely discharged from the emergency department, and you can consider starting them on preventative therapies. Moderate disease will require functional testing to determine if that's causing a perfusion deficit, and they may need a cath. And severe disease, cardiology consult, and cath. So over the last 10 years, there have been some great studies done, and they've identified some wonderful benefits of coronary CTA. It has been shown to decrease the time to diagnosis in the emergency department, the time to discharge in the ED, and the overall cost of care in the ED. All this is going to make your boss happy. In addition, coronary CTA can provide information on plaque characteristics that can help to identify some high-risk lesions. Coronary CTA imaging may also identify alternate diagnoses for a patient's chest pain. So things like a PE, dissection, effusions, pneumonias, malignancies can sometimes be picked up. And importantly, a 2018 randomized controlled trial that came out of Scotland followed patients for 5 years and showed that those who underwent coronary CTA versus standard of care, usually with stress testing, were more likely to be started on preventative medications. So things like aspirin, statins, antiplatelets, and lifestyle modification. This study showed that the coronary CTA route was associated with a lower rate of coronary heart disease and non-fatal MI versus standard of care, which is thought to be due to the earlier identification of coronary artery disease and the initiation of these preventative medications. Another great point is that coronary CTA has been shown to provide this idea of a MACE-free period. MACE, here again, cardiac death and non-fatal MI. A 2011 follow-up study to that 2009 study I first mentioned showed that normal coronary artery imaging provided a 2-year MACE-free warranty period. And we also have data from a 10-year follow-up study. Here, patients with normal coronary CTA results had an annual event rate of 0.04%, which translated to an event-free survival period of 10 years against cardiac death and non-fatal MI. But of course, some downsides have been identified. Those who go down a coronary CTA pathway end up with greater overall radiation exposure. And some studies show an increase in the rate of downstream testing and the rate of invasive coronary angiography. And there's also concerns that it increases your overall cost, not just the cost in the emergency department going down. But there are some caveats. Newer studies show that while downstream testing and invasive coronary angiography increase in the first few months as compared to standard of care with stress testing, these rates end up being similar at the 5-year mark. And important to mention that those who have a coronary CTA and then proceed to cath end up having more disease on those caths versus those who have caths after stress testing. And even some new studies show that overall cost of care may not be as significant as previously thought. Another downside to those who undergo coronary CTA is that they are still coming to the emergency department for evaluation of their chest pain. And while coronary CTA finds the stenosis, it's always unclear if these are clinically relevant stenoses causing ischemia. To determine this, patients will then require a functional test since coronary CTA shows anatomy only. But again, this last point may be changing. What you're going to see next for coronary CTA is a functional component to the imaging called fractional flow reserve. This is a calculation that looks at flow before and after the stenosis to help determine its clinical significance. And as always, we have some current guidelines that can help to inform our practice. So the NICE guidelines are coming out of England. They're evidence-based recommendations that state that coronary CTA is the first choice diagnostic test for typical and atypical angina or those with STT changes or Q waves on their EKGs. But what we're probably all more familiar with is the 2018 ACEP clinical policy. These provide a level B recommendation to not order further diagnostic testing, including coronary CTA or stress test, prior to discharge in low-risk patients in whom MI has been ruled out to reduce 30-day MACE. Instead, what you can do is arrange follow-up in 1 to 2 weeks for them. But if that's not available, you can consider further testing prior to discharge or observation. So let's go back to our case. We all know that Mrs. T is low risk. She's 52, hypertension, hyperlipidemia, atypical chest pain with a negative workup in the emergency department. So in the heart score, she has a 0.9 to 1.7% risk of adverse cardiac event. Is coronary CTA appropriate for her? Well, I'm a PGY3 and a resident like most of you, and this is really a controversial question. I lean towards ordering a coronary CTA for her because there is this sense of diagnostic certainty it can provide. And also there's the fact that I may be able to reassure her that she has normal coronary arteries, she is low risk, and she has a MACE-free period. Not to mention, I may be able to find an alternate cause of her chest pain. So taking that all together, it's really appealing to me. Whether it truly reduces overall mortality, I think is still to be determined. So in that low risk chest patient who you think will benefit from some of that reassurance, or in someone where we want to start the workup, for example, someone who is not yet hooked into the system or is going to have a difficult time following up, I think this is a good test. So of course, it's an individual consideration, and it's going to depend on the time of day and the coronary CTA capabilities of my workplace. But I will be incorporating this into my future practice. So big thank you to Dr. Holly Thompson and Dr. Bonnie Brown for helping me with this presentation.
Thank you, Dr. Rusnak. That was a great presentation. We are now going to move on to the panel discussion where the three of you can kind of fight this out. I'm also going to introduce Dr. Kaushal Shah. He's actually the vice president of our ALL NYC EM committee. He's also the vice chair of education at Weill Cornell Emergency Medicine Department. Dr. Shah, I'm going to have you take away this discussion.
Sounds good. Thanks, Fraso. So I am super impressed with all of your presentations. I really want to commend you guys. This is probably one of the most important topics in emergency medicine. We deal with this every day. I know we've talked about central lines, we've talked about intubations, but really low risk chest pain and chest pain in general is a daily question for us. So I really want to start with, and we don't have a lot of time. So for people in the audience, if you have a question, throw it in there now. Everything's been about the Jets and the Giants so far, so feel free to ask something about chest pain. But the thing I want to ask, and we're going to make this quick, is now that we have Miss D in your ED, and I'm going to go with Francie thinking I'm at the right time of day, I'm going to get a CT coronary on her. Joe and Duncan, now that you've heard all the arguments, where do you guys stand? And I need a quick answer because then I have a follow-up question.
My quick answer is I'm not going to send Miss D for a coronary CTA. I've got COVID. I've got Candida auris in my emergency department. She's already been there for like 7 hours probably anyway. I appreciate what Francie was saying about the 5-year MACE period, which is nice, but I'm pretty confident that her risk of MACE in 6 months is also super low. So as long as I can get her follow-up within 6 months, I'm super happy sending her home.
Okay, that's a 10-year warranty, I think is what Francie said, if there's no calcium there. So that's pretty good. All right, Joe.
Yeah, I think I would hedge a little bit. I mean, I think on the one hand, understanding her underlying coronary physiology and anatomy, I think is important. She's 52, there is a chance there's something there. I think ultimately, because we don't know how many of these underlying plaques will ultimately rupture, so it's two different processes, it's hard to decide whether or not that will give us any long-term prognostic value. I think it probably does have some value in the long run, and it depends on if it's something that's easily obtainable. If it's something that's easily obtainable, I think it probably would be worthwhile in a patient like this.
Yeah, so, I really want to touch on this idea that we've already brought up, but I think it's worth emphasizing that when patients, especially low-risk patients, when they come to the hospital, they're not looking for MI or no MI, right? Most of them will tell you, I don't think I'm having a heart attack. I had chest pain last night. I just want you to tell me what's wrong with me. And so that's when you get into the question of, do you tell them that you don't have acute coronary syndrome, which you shouldn't, because you can't tell that from, a troponin or two. And so, what if they're not low risk? What if they're just above that and they're moderate risk? What are you guys going to do? So Francie, I'm going to start with you since you talked about the coronary CT. Where do you stand?
I think that you can certainly use a coronary CTA for them. There's going to be some caveats, and it's going to be sort of patient specific, but you may be surprised and get a negative coronary CTA, or you may be able to recategorize people into that moderate, from moderate to mild, depending on what they have. But you'd have to see what sort of prior testing they've had. If they've already had a coronary CTA, something like that, then it's time to move on.
Francie, before we move on, there's a question for the panel, which is, can you speak a little bit about, you did talk about the radiation exposure, but what about false positives in the coronary CT group? And then they end up with more testing and then a cath, which they didn't need. Can you talk a little bit about how often that happens?
I don't have a specific number on how often it happens, but it certainly happens less than stress testing.
All right, sounds good. All right, Joe and Duncan, thoughts on a non-low risk chest pain, and would you do any follow-up testing?
I feel like this is that classic, like, wastebasket answer of shared decision making. I think it depends. I think some people come in and they're not going to be low risk no matter what. They're like 1,000 years old and are daily smokers and have 19 comorbidities, and their EKG is always messed up, and they have CKD, so there's always a little bit of troponin. Like, I think probably the standard of practice is if that person comes in complaining of chest pain, they're probably going to stay the night, whether that's inpatient or in an observation unit. But I don't know, that Weinstock paper with the paper that was showing like 2 negative troponins, if they do have negative troponins, even moderate risk. I think if I had a conversation with the patient's cardiologist and they were like, oh, I can see him in the office tomorrow, it's fine. And if they wanted to go home, maybe this will ruffle some feathers, but yeah, I think it could be okay to send home a non-low risk chest pain.
Yeah, I mean, I think there is a value to evaluating these people over time. I think we often underestimate that there is a value to time and giving a little bit of lag, especially for patients that might be functionally compromised. So these patients, I think it's worth admitting and observing over time, whether or not that means you immediately go for some kind of more invasive testing, or you're just observing their progress over time. I think that's probably valuable, especially if they're intermediate to higher risk.
So, okay, just to summarize, because we have 1 minute left, the message I think I'm getting from all of you is that the low risk chest pain people probably and almost certainly don't need further workup in the ED, but you're not opposed to having them follow up and and again, being a patient advocate, doing shared decision making, plugging them into the system, because these people are not zero risk for some kind of coronary disease, but they're not having an issue at the moment. And so as emergency physicians, we can advocate, but we definitely don't need to increase cost, increase testing by admitting those folks. We didn't get into observation units, but I see Frossel's already on, who's going to cut us off. Thank you guys. You guys did a fantastic job.
Thank you.
Thank you, everyone. Didn't mean to cut you guys off. That was a really great discussion. And honestly, those lectures were amazing. You've really set the bar really high for resident lecturers and for attending lecturers. So thank you for those talks, everyone. All right, one more time, I'm putting up the QR code. If you haven't registered, please scan the QR code. It helps us keep track of how many people and how we can tailor our conferences to you. We're gonna move on to our last sort of back-to-back lecture and panel discussion. We're gonna be talking about ketamine because no one can ever get enough ketamine. And to start us off, I'm going to introduce Dr. Ruben Strayer. He doesn't need an introduction, but here we go. He's a famous emergency medicine physician in the world of FOMED. He also works clinically at Maimonides Medical Center. We are honored and really happy to have you here, so can't wait to hear what you have to say.
Hi, everyone. Can you guys hear me okay?
Yes.
Great. So I'm Ruben Strayer. In a span of 10 minutes, I'm going to explain the reasons and the role of ketamine as a treatment for severe agitation. The reason to use ketamine as a tranquilizing agent, and I use that term very deliberately, is because nothing comes close to matching ketamine's effectiveness for immediately, reliably, and safely allowing clinicians to control a dangerously agitated patient. There are now dozens of studies attesting to this. I've made many of them available at emupdates.com/calm with a K, so that Mark can review them in the next 9 minutes before attempting a rebuttal. Ketamine in dissociative doses will cause nearly every patient, regardless of how big, strong, psychotic, intoxicated, or borderline, to become calm and still in about 3 minutes as they continue to breathe and protect their airway. It doesn't matter whether the patient is intoxicated with alcohol, methamphetamine, cocaine, PCP, from which ketamine is derived, or ketamine itself. If someone uses ketamine recreationally and then becomes a raging, mad, dangerous lunatic, ketamine dissociation will make that patient calm, and it can be delivered with extraordinary reliability by the intramuscular route, with little concern about finding the right dose because of ketamine's unique dose-response curve. You can't discuss ketamine for any indication without understanding its effects across its dose spectrum. Ketamine has 4 phases of effect: analgesia, recreational, partially dissociated, and fully dissociated. At very low dose, ketamine has minimal effect on perception or emotion, but is a powerful analgesic. As the dose increases, the patient will have significant perceptual disturbance, but they know what's going on. They can have a mostly normal conversation. And then at higher doses, you enter into partial dissociation, where the patient is disconnected from reality, but still conscious. This is generally where you want your patient not to be. But once you pass the threshold of dissociation, which occurs at about 1 milligram per kilogram IV or 4 milligrams per kilogram IM, the patient becomes unconscious, unaware, uninteractive, and still. The flat segment at the end of the spectrum is quite important. Once the threshold of full dissociation has been reached, higher doses prolong duration of action but have no additional effect. This feature gives ketamine a remarkable safety profile. You don't have to worry about ketamine overdose. That doesn't really exist. You just have to make sure you've given enough. And enough is a dissociative dose, which will make the patient calm and still, and usually breathing and handling their secretions, but not always. And here lies the most important thing to know about ketamine dissociation. Every patient who is dissociated with ketamine for any reason and not already intubated may develop hypoventilation or apnea from a variety of causes and must be monitored with full PSA setup in a resuscitation environment with an airway-capable provider at bedside continuously. And that's why it makes sense to intubate these patients if they are delivered to you by EMS and you are a single doc working an overnight shift in a single doc shop, which is what happened in John Cole's often cited study, where a significant number of patients got intubated. This study is now often cited in popular media because of what's going on with police and ketamine. It's very clear and apparent from many other studies and discussions with Dr. Cole himself that nearly all the patients that receive dissociative dose ketamine for agitation and get intubated would have done well had they not been intubated. But it is hard for some emergency docs in some settings to stand there and watch a GCS3 patient until they emerge from dissociation. By the way, we would prefer that you use the terminology GCS3K because all dissociated patients will be GCS3, which is why ketamine is not the right agent to manage the routine agitated drunk. I've been talking about ketamine for agitation for many years. I've worked in a variety of New York City hospitals that see a lot of agitated patients, and I think I have used ketamine for this indication half a dozen times in 15 years. Whereas I have used haloperidol, droperidol, and midazolam hundreds of times, probably thousands of times for agitation. Ketamine is not to be used for routine agitation. There are two indications to use ketamine for agitation. Firstly, for the patient who is uncontrollably violent, meaning almost always a big, strong man who is intoxicated, cannot be safely subdued by available resources, and is therefore an immediate threat to himself or others from the agitation and violence itself. The second type of patient is very agitated, but you also have a high concern for a dangerous medical condition that requires immediate management. The most common example is the agitated polytrauma patient, but this also applies to an agitated patient with a temp of 106 or an agitated patient with a saturation of 50%, ripping off his face mask. These are patients where you do not have time to calm them down with a drug that may or may not work. You need to establish control immediately or they will die. Which brings me to the ketamine tranquilization litmus test, where you ask yourself, if this patient that I'm considering using ketamine to sedate, if this patient ends up intubated, would that be reasonable care? If yes, great. But for 99% of agitated patients in the emergency department, the answer is going to be no. And so for 99% of emergency agitation, you should use a conventional titratable sedative like droperidol, haloperidol, or midazolam. I generally prefer a combination of droperidol or haloperidol and midazolam, depending on what's going on. And this will work very well most of the time. But depending on the doses, you have to accept that it might not work immediately and that you might have to redose to get your patient calm. For the butorphanol neuroleptics, you have to accept a delayed onset of action, especially with haloperidol. And you have to accept the side eye that you're going to get from toxicologists and pharmacologists because of the theoretical risk of QT prolongation or lowering the seizure threshold, though these concerns are really vastly overblown. Toxicologists love midazolam. Mark loves midazolam. I also love midazolam, and 3 to 5 milligrams of IM Versed will safely and effectively manage most agitated patients, but you will run into problems on both ends of the therapeutic window with midaz because the therapeutic window is relatively narrow. The problem with using midazolam as a single agent for routine agitation, most of which is alcohol related, is that at doses that are reliably safe, 2, 3, 4 milligrams, it's not reliably effective. And at doses that are reliably effective, like 5, 6, 7 milligrams, it's not reliably safe. You will absolutely see dangerous respiratory depression at the higher doses, especially with alcohol on board. So be careful with higher doses of midazolam. So my take-home message is that ketamine is rarely the right agent to manage agitation in the ED. But when it is the right agent, it is essential. So know when to use it: uncontrollable violence and severe agitation with high concern for a dangerous condition. Know how to use it safely, which is in a full PSA setup. And get good at using droperidol, haloperidol, and midazolam for everyone else. Thanks for your attention. All right, over to you, Mark.
Thank you, Dr. Strayer. I'm going to introduce our next lecturer. That's Dr. Su. He's going to be talking about a different approach to ketamine and some different thoughts behind ketamine. He is an NYC famous toxicologist and he's also the director of the New York City Poison Control Center. He's the associate professor at NYU School of Medicine. So let's welcome him, and I'm excited to hear what you have to say.
Excellent. Thank you. Can you hear me?
Yes.
Perfect. Thank you. Thank you very much for that kind introduction, Frosso. I'd like to also thank the ALL New York City EM group for inviting me to speak on this very interesting subject. And I appreciate Ruben Strayer for the introduction to the topic and the sharing of those references at the beginning of his talk. So all of us work in extremely chaotic and very busy emergency departments. There are things going on all the time, a million things happening, helicopters flying in, people running around, lots of things. So we work in very busy and a very chaotic environment. And that's just what we do in emergency medicine. One of our main goals and objectives during almost any of our shifts in emergency medicine is to empty out the ED completely and not have any patients. Of course, that's not really true, but if there are any patients, we'd like them to be happy and resting as comfortably as possible. So the reality is that this type of placid and calm and quiet environment doesn't happen in the emergency department. We have patients. We have patients who are acutely ill. We have patients that require attention, and many of them require immediate attention. So this is most certainly the case when it comes to patients with agitation, and as Ruben described, patients who have excited delirium and extreme forms of agitation. So the excited delirium syndrome is characterized by catecholamine excess, metabolic acidosis, multi-system organ failure, altered mental status, hyperthermia. It's a life-threatening emergency. This is a life-threatening emergency that we encounter, much like a STEMI gunshot wound to the chest. If the patient doesn't receive immediate attention, they could suffer severe adverse sequelae, they could even die, and they need to be sedated and stabilized very quickly. So fortunately, as Ruben discussed in his talk, we have a lot of options. We have several options that we can use to sedate these patients, including the drugs that are listed in this table. So you see here, as Ruben discussed already, that there are basically 3 classes of medications that we can use: benzodiazepines, antipsychotic medications, and ketamine. Interestingly, in this systematic review, you see that ketamine has received the most attention in terms of formal research. Now, since time is of the essence in most of these patients, in fact, all these patients with agitation, we need a medication that has a rapid onset. And so you can see here in this table that both midazolam and ketamine both have a very rapid onset. Ketamine might be slightly faster, according to some other studies. We're talking seconds here, but in general, both of them are very fast. But onset isn't the only thing that's important. The duration effect needs to be considered as well. So Ruben talks about midazolam requiring additional doses, but ketamine is so short acting that ketamine often requires additional dosing as well. So I don't think that's a property that's unique to midazolam. And in fact, it is often noted with ketamine. And this is important when we're sending patients to CT scan and doing other things and sending them out of the emergency department. So we know that ketamine is great for procedural sedation. It helps us to avoid having to do less than ideal maneuvers to accomplish what would otherwise be a simple procedure. In this case, we have a young kid who's getting a forehead laceration. So ketamine is very useful for that. But when it comes to agitation and excited delirium, this is not the controlled setting of procedural sedation. And ketamine is not the best drug for this setting. There are many disadvantages to the use of ketamine, and let's count the ways. So in terms of pharmacology, ketamines are dirty. It's a promiscuous drug that affects many different receptor types in the body, as I've listed here. Some of these receptors include the NMDA receptor, sigma receptor, the cholinergic receptor, a bunch of different receptors. Activation of these multiple receptors can lead to unpredictable and potentially harmful side effects. So when it comes to these side effects, it's important to recognize these, and there are many listed here. Some of these, they're not so important, right? So little secretions, vomiting, not such a big deal. But when you look at these other complications that are associated with ketamine, these are a big deal. The need for intubation, laryngospasm, increased heart rate, blood pressure, and the potential exacerbation of psychosis. The list is quite long. And in fact, in a paper written by Rubin in 2008 regarding the use of ketamine for procedural sedation, he writes in this paper, and I'm just going to read what's in the paper, ketamine causes centrally mediated catecholamine reuptake inhibition that generally results in a modest increase in heart rate and an elevation of blood pressure, which on occasion can be marked. Furthermore, however, whereas the stimulation of cardiac output is an advantage in the hypotensive patient, I recognize that, the resulting increase in myocardial oxygen demand can be consequential. And in patients known for or at risk for coronary artery disease, caution is prudent. Does that sound safe? I'm not so sure. So now when it comes to psychiatric disease and patients with schizophrenia, a large proportion of patients presenting for the ED with agitation or excited delirium can't provide an adequate history, and they could have underlying psychiatric disease, as depicted here. Now, ketamine has been shown to exacerbate psychosis in patients with underlying schizophrenia. And as the second paper shows you, this is even demonstrated at low doses. So ketamine would not be the right choice of sedation in these agitated patients for this reason. So now let's get to the elephant in the room. Ketamine and intubation. Rubin says the ketamine is very safe and not associated with many airway complications. I beg to differ. So I myself love the Pittsburgh Steelers and a good intubation. It's such a nice feeling to get a good look at the cords and pass that ET tube through right through them. And in fact, I enjoy intubating so much that the last time I did it was on a Wednesday conference day, back when the residents used to go to conference, when all the residents were at conference. That day, I was working with my co-attending, Rana Biari. Patient came into the hospital, obtunded, altered mental status, GCS was less than 8, and the patient clearly needed intubation. So I literally pushed my friend and co-attending, Rana Biari, away from the head of the bed just to do the tube. Luckily, I got it, and Rana and I are still friends. But seriously, probably the most important reason why not to use ketamine in the setting of agitation is because of the requirement for intubation. In this study by John Cole has done a lot of great work on this topic, looking at pre-hospital use of ketamine for agitation. They had a whopping intubation rate of 63%. 63%. That is an extremely high number. Now, one could argue that this was a single study, this was a pre-hospital setting. I've spoken to John Cole myself personally too, and it seems to potentially have been driven by a single provider. Now, looking at this meta-analysis by John Cole and colleagues, looking at ketamine use in the settings of aeromedical transport, EMS, and in the ED, the overall intubation rate was lower, but still 197 out of 645 patients, or 30.5% of them, got intubated. That's a very large number. So now you might say agitation, patients with agitation and excited delirium are sick. And as Rubin described, it may be acceptable to intubate this many patients. But I would just counter this argument by saying that intubation is not benign, and all the patients that we see in the ED, typically less than 1% of them should require intubation. So this very high rate of intubation that we see with ketamine must be considered and it can't be discounted. And so otherwise, if we continue to use ketamine routinely, we're going to be filling our busy EDs with patients who get intubated as a complication of sedation. And finally, just to illustrate that ketamine-associated airway complications can also occur in a delayed fashion, in this case that we received recently, a patient presented to the hospital he was 38 years old, he was hypotensive, tachypnic and hypothermic with altered mental status. He was given ketamine 100 milligrams IV 6 times, 600 milligrams, and then an additional 200 milligrams IV for CT scan. He desatted. That initially those desats improved with Larson's maneuver, but over the next 5 hours, he subsequently had 3 airway calls, which initially were improved and treated with suction. That was fine, but by the 3rd time, he had jaw clenching that prevented adequate suction, and ultimately he was intubated. So this is just a single case, but this is reported with ketamine that there is a need for delayed airway intervention after administration. And mind you, the last dose of ketamine in this particular example was 5 hours. He got intubated 5 hours after his last dose. So as Ruben mentioned, he knows me well. So we see that my preference is benzodiazepines. And so we look at this study here that compares midazolam versus some antipsychotics, olanzapine, ziprasidone, and haloperidol for treating acute agitation in the emergency department. What do we see? Midazolam, 1 out of 127 patients are intubated. Benzodiazepines are predictable, they're rapid in onset, and they have fewer side effects. Looking at this particular study, in which the combination of midazolam and droperidol for sedation was compared to some other antipsychotics, and not just midazolam alone, there were some adverse airway events, but these were corrected easily, and they had a 0% intubation rate with midazolam droperidol combination. So benzodiazepines have fewer side effects compared to ketamine. They're more predictable. They're associated with lower rates of intubation. And as we always say in toxicology, when are benzodiazepines ever bad? So benzodiazepines are your friend. Ketamine is not in this setting. Remember, all of us, we work in very busy and chaotic emergency departments that have patients. We want to minimize chaos, and ideally, we want everyone to be resting comfortably and not intubated. So I thank you for your attention. I thank all the present and future toxicologists who provide me with the material and inspiration for this talk. And I welcome the panel discussion. Thank you.
Thank you, Dr. Sue. I'm going to invite our panel member. She does not need any introduction. Dr. Beck Esme is going to join us. She's an ALL NYC faculty member. She is the Assistant Residency Director at Mount Sinai Morningside West, Editor-in-Chief of Feminem, Associate Editor of Rebel EM, and a frequent contributor to the MRAP podcast series. So I'm excited to let you take over from here, Dr. Beck Esme, and let's get to the discussion.
Hi, thank you, everyone. I am very much looking forward to this discussion because a lot of what I learned about sedating agitated patients, I have learned personally from Dr. Strayer or Dr. Sue, or actually even from Dr. Cole, who was my attending when I was a medical student at HCMC and regions in the Twin Cities area. So this is a very fun topic for me. I think you guys really pulled out a lot of nuances between these. The first question I have for you that I want us to discuss, and audience members, please feel free to add things to the question chat so we can make sure to answer your questions. But I want to know how you guys are doing this in practicality. I think you made some good arguments in favor of various medications, but are you going for pinning down a patient and giving them an IV? Are you stabbing them through their genes with an IM? A lot of times nurses will say that these volumes of medications are going to be too high to be given at IM. Is there any max that you can be giving for any of these medications? Can you tell me what this actually looks like when a patient is going crazy and destroying your resus room?
I'll take a first stab at it. Again, just want to reemphasize that the vast majority of patients who come in agitated should not be receiving ketamine as a treatment for agitation for many of the reasons that Mark just elucidated. But for the occasional patient who requires immediate tranquilization for a high degree of danger, the right thing to do is to assemble the amount of force that you need to control the patient. That's as many, usually big, strong men as you can throw at the patient. Ideally, one for the head, one for each extremity, not including the nurse who's drawing up and administering the medication, not including the physician who's orchestrating the resuscitation or the takedown, if you will. But a lot of people show of force. You'd like to apply face mask oxygen to that patient. You'd like to make sure there's no dangerous restraint holds in play. So if there's a hog tie, that some of our patients might come in a hog tie, or at least they used to. We don't do that very much anymore, thankfully. If someone is compressing the neck or the chest, if someone is covering up the mouth with a gloved hand, which often happens when these patients might be spitting, you want to make sure you deal with all of that first. And then as soon as feasible, after the patient is held down, you want to deliver the appropriate medication, in this case, ketamine, if someone really needs it. Through the clothes intramuscularly. Definitely don't want to try to start an IV. That's very dangerous because starting an IV is hard on someone who's thrashing about, and the delays associated with starting an IV on these patients could be much better spent. That time is much better spent just waiting for the patient to calm down after an IM shot. Trying to start an IV exposes your nurses to needle stick risk. Bad idea. The last point has to do with volume. And depending on the ketamine concentration that you have in your department, you could run into trouble with volume. There's a lot of nursing protocols that limit volumes for intramuscular injection to 5 cc's. However, there is a fair amount of evidence that you can give much more than that without trouble. Certainly 10 cc's, actually up to 20 or 30 cc's is safe. You may have trouble getting your nurses to do that. So I've had that happen to me once, and I just took the syringe myself and gave all of the medication into the thigh, and that's my approach.
I have two comments on that before I toss it back over to Dr. Su. First, I think that the point about there's a delay on either end, whether you're putting in an IV or you're waiting for the IM medications to work, is a really good one. I think often we'll hear people say, sometimes from the nursing staff, sometimes from the physician staff, oh, if we give it IM, we have to sit here for so long. There is always at least 5 to 10 minutes of wrangling someone down, getting an arm ready, then you'll get the IV and it goes flying when the patient gets loose. So I think you're right that waiting on the medication has already been administered end is probably safer. What was the second thing? Oh, the second thing was regarding volume. If you have to, you can split into 2 syringes, 2 providers, both thighs through the jeans if you need to. I've seen that done to great success. Dr. Su, did you have anything to add to your technique for how this happens in practicality?
I just wanted to say, I think Ruben emphasized this, or mentioned this, but I think the emphasis here should be on provider safety. These patients are a risk to not only themselves, but to staff, and they could be swinging and potentially hurting staff. And so this is a very serious emergency. This requires hospital security and as many large people as you can get available to physically restrain these people until they can get the chemical sedation. And typically, IM is the safest way because, as Ruben mentioned, the needle sticks potential needle sticks with IV pose additional unnecessary risks.
I think one of the really challenging things with these patients is the redosing of medications and when to combine medications, when to switch medications, how long to wait. So let's just take it kind of one circumstance at a time. It sounds like both of you agree for the standard agitated patient, it's not going to be ketamine. It's going to be potentially a benzo with a combination of a benzo alone, a benzo with an antipsychotic, or potentially an antipsychotic alone. You've given that IM. How long do you wait? What is your initial dose that you like to give? What is your cocktail or combination you like to give? And then what do you switch to if those things are not working?
So just to reemphasize that using ketamine in this context is only for the initial gaining control of the patient. Once this is like, so you're confronted with a patient who is very dangerously agitated. You think it's a very high priority to gain immediate control. You don't want to take the chance that you might need to redose. That's where ketamine's strengths come into play. And I would submit that once you get the patient under control with ketamine, you're going to try to then move on to address the underlying problem. You may not know what the underlying problem is at the outset, but someone comes in throwing stretchers across the triage area. You can take control of that patient very effectively with ketamine. That patient needs to be put on a resus monitor. That's when you get your line. That's when you get a better history. You try to figure out what's going on. And then you're going to tailor your further therapies to the underlying problem, which could be a cocaine intox. It could be alcohol withdrawal. It could be schizophrenia. Whatever it is, you're going to try to tailor your therapies to that. And you're going to be ready to redose with ketamine. As Mark said, it's not long acting. So even IM ketamine is going to start to disappear in 15-ish minutes, maybe 30 minutes. And so you need to be prepared to redose. But in my experience, and I think that the literature bears this out, these patients generally emerge from ketamine tranquilization gradually and in a somewhat calmer state than when they came in. And you generally have time and you have an IV. And again, more history, you have your drugs ready. It's generally not a problem to maintain control over those patients. I'll let Mark comment on his approach then.
So just to reiterate that, ketamine is to get them down when they're going crazy. Then you're going to tailor your medications, potentially with a benzo or an antipsychotic if it's cocaine or alcohol withdrawal or psychosis, that's the underlying problem, to actually keep them down for longer if you need more than that 15, 20 minutes.
Exactly. I don't think redosing ketamine for ongoing agitation is the right approach.
Which is what happened in that case that Mark or that Dr.
That's right.
Sue showed, was repeated doses of ketamine that led to this problem. Dr. Sue, do you want to comment?
Yeah, so typically my approach would be monotherapy with a benzodiazepine. My preferred benzodiazepine is going to be midazolam. I'm going to typically give 5 or 10 milligrams intramuscularly to the patients. I'll wait a few minutes, maybe 5, 10 minutes. If they need to be redosed, I will go back with more midazolam, maybe another 5 to 10. And again, reassess in about 5 or 10 minutes. If they need more, I might try maybe another 5 or 10. This is just kind of based on anecdotal personal evidence. And at that point, if I'm not gaining adequate sedation, I'm probably going to go to potentially other GABAergic agents to facilitate or to help, such something like etomidate. And maybe in some cases, I would use a little bit of an opioid like fentanyl, something to give me rapid sedation of the patient to where I can get an IV into the patient. And at that point, once I get the IV established, I'm going to give them longer sedation, longer acting benzodiazepines, not midazolam because it's too short acting.
So midazolam, 5 to 10 milligrams IM times 2, spaced out by 10-ish minutes, 5 to 10 minutes?
10 minutes, yeah.
5 to 10 are the good numbers for you. And then once you've done that twice, you're adding on some other medication.
Probably.
I will note specifically that you did not say any of the antipsychotics. Do you want to give us a toxicologist's comment on the antipsychotics in the undifferentiated agitated patient?
The antipsychotics all of them typically have a longer onset of sedation. And although their duration effect is quite prolonged, I need somebody sedated immediately. And for that sedation, if I need that sedation immediate, the antipsychotics are not going to help me in that very acute need for sedation in the minutes, as opposed to the half hour or hour later, or when the patient still needs sedation, but it's less important because I have an IV and I can give other medications as well.
Dr. Strayer, this is actually a good one for both of you. It's coming from Kevin Molyneux in the chat. He's asking, is there any concern about PCP and ketamine both working on the NMDA receptor, or is this generally not ultimately clinically relevant? I guess his question is coming from the fact that those patients that are generally throwing stretchers around could be on PCP. So are you at all hesitant to use this in those situations?
I think that these are the patients that honestly are most in need of ketamine tranquilization. Actually, my department just published a case series just a couple days ago around an electronic dance music festival, which included using ketamine to sedate patients who were intoxicated with recreational dose ketamine. So as I mentioned, the answer for severe agitation associated with PCP or ketamine done recreationally is the same as severe agitation from any cause. If you need to get the patient down right now, you don't want to take the chance that you might have to redose, then the ketamine will work for sort of whatever ails you. You don't have to be concerned about too much NMDA activity. These patients will become dissociated, calm, and still. Unlike procedural sedation patients who will see an increase in heart rate and blood pressure, these patients are on sympathetic overdrive. And what will happen with ketamine, and we know this pretty clearly from the literature now, is that they will see a normalization of their vital signs, in marked distinction to the relatively calm patient who gets a PSA dose of ketamine who becomes hypertensive tachycardic. These already very hypertensive tachycardic patients will see a normalization of their vital signs with ketamine.
How about in the pre-hospital setting? In some practice environments, paramedics or medics will have various degrees of airway capabilities. Do you think that this is a safe medication for them to be using in the extremely agitated patient pre-hospital?
I would say that only providers who have the capability to do advanced airway management should be using ketamine in dissociative doses because of the risk of hypoventilation and apnea that is always present whenever ketamine is given in dissociative doses. So I don't recommend that providers who don't have the capacity to intubate use dissociative dose ketamine. This is always sort of region by region, and every pre-hospital service has their own culture, but giving dissociative dose ketamine to a patient without the capability to manage their airway is a recipe for problems.
I'd just like to add here, Jenny, that I've been in correspondence with John Cole recently, and he says that at his medical center, you know, the paper I quoted of his study with 63%, of course, that's an extreme example, but he says that they still have a relatively high intubation rate of somewhere around 25% in the pre-hospital setting. And because of that, I have concerns about the use of ketamine. I have large concerns about using ketamine in the pre-hospital setting.
Yeah. Okay, we have 1 minute left, so I want to hold both of your feet to the fire. Dr. Su, is there any agitated circumstance in which you would use ketamine? You've given midazolam a few times. You've given some opiate or something else. Would you ever pull the trigger on using ketamine? Have you done it?
I have not. I haven't done it. I guess the answer to this question to me would be is if I've exhausted all of my typical medications that I give for acute agitation and the patient is still not in control and not adequately sedated and still a threat to himself or to others, potentially at that point I will try ketamine.
Okay. Dr. Strayer, is there any dangerously acutely agitated patient, the extreme type patient that you're talking about using ketamine for, in whom you would not use this? Is there any circumstance that's the exception for you?
Yeah, so if I know that the issue is, for example, cocaine intox, and I feel like I have adequate personnel, then I have no problem with giving someone 10 to 20 milligrams of midazolam, which is sort of an antidote for stimulant-induced agitation. That said, if you just, some people are benzodiazepine resistant, and you just need to have that sort of ace in the pocket ready, which will work essentially every time if the patient becomes uncontrollable.
Thank you so much.
Thanks, everyone.
Great, thank you.
Thank you, everyone, for that panel discussion. And last but not least, we have one lecture to close us off for the day, kind of to tie in everything that we've talked about. Awesome. Thank you. Dr. Gilberti, I'll have you lead us off for the evening.
All right. Thank you, Foss. So excellent discussions. I feel like we have to have a rematch for a lot of these matches, although for Mark and Ruben, it's probably going to be round 12 coming up. I'm Brian Gilberti. I'm from NYU Bellevue program, and I want to shift gears and talk about FDR for a second. He was our beloved president. He was a national hero. But what a lot of people don't know about FDR is that he was a victim. He was a victim of medical, not malpractice, but of medical practice. And here he is. Here he is at the Conference of Yalta. He's flanked by Churchill and Stalin as the Allies were marching towards their victory in World War II. But what nobody knows in this photo, or nobody could expect, is that within a couple of weeks of taking this photo, FDR would be dead. And he unfortunately would not see the demise of his nemesis, Hitler. He would not see the rise of the US from the ruin that was laid by World War II. And he missed all this by a matter of weeks and months, respectively. But why is that? Why would this man, relatively young gentleman, die so unexpectedly? You know, we found a smoking gun. Luckily, his physician kept meticulous notes of his care of the president. And we were able to piece together a plot of his blood pressure over the last 10 years of his life, which is here. And you see in the top part of the chart, you have the major world events, but in the bottom part of the chart, we have the documented signs of end organ damage. And as you could see going towards the right, FDR's blood pressure was approaching 300/190, a systolic of 300. Why? Why did his physician, a seemingly competent, patriotic physician, leave his blood pressure unmanaged? There were agents back in the 40s that could treat this. Why would this go without treatment? And the reason is, the main part of the reason is that back then, we thought we knew better. We knew that FDR had angina, and we knew that angina was associated with CAD. And there was some sort of critical stenosis somewhere in his coronary arteries. So the thinking was, in order to push the red blood cells past this lesion, we have to maintain the president with wildly uncontrolled blood pressure. And you know, maybe the higher the better. Now, to people on this call, this is ridiculous. This is a ludicrous conclusion to come to. And it's not a surprise to us that FDR died from a hemorrhagic stroke, but it was a shock to his physician, who on April 13th, 1945, when he passed away, said that it came out of clear sky. It didn't. This should be a cautionary tale for all of us here, to not fall into these traps and to not think that we can outthink medicine and try to reason our way to the justification of an intervention. Because when you get a bunch of doctors together trying to reason their way through how to best manage a patient, I bet they're often going to be wrong. And what's worse, they may even harm the patient. We must rely on data to support what we're doing. And the history of medicine is chock full of examples of this. And low-hanging fruit, it's easy to point out bloodletting since the beginning of what was considered medicine. But there are some silver-haired attendings still working who can remember a time when we were still bloodletting in the emergency department for fluid overload. It's not so far in the past. But a little more recently, hydroxychloroquine has been touted as an amazing drug that can squash COVID bigly and treat it and perhaps even prophylax against infection. Up until the best data we have shows that it actually doesn't help all that much with treatment or prophylaxis. You know, this, I think, hits a little bit closer to home because how many patients did we see in the trenches here in New York City during the height of the pandemic who were sent in or who came in on their own after being prescribed plaquenil and azithromycin by their primary care provider without doing any evaluation over virtual urgent care, to only see that their QTCs were going through the roof. Last thing that we needed. But again, to bring it back to the first floor where we're at, I want to talk about 3 examples specifically in which this type of thinking that we can rationalize our treatment has actually worsened care. And I'm going to talk about how it's creeped into our care for hemorrhagic strokes, for cardiac arrest, and for trauma. Now, I think anybody who looks at these images is scared, and it'll prod your amygdala just taking a look at the one in the middle. At least it does for me. And when these images show up on your PACS, it just confirms what you feared the most. And it's only natural for us to want to intervene, to do something. This is wretched pathology that threatens the patient's life and well-being. So we want to do what we can, and not just stand there, to improve the chances of survival and also neurologically intact survival so that the patient could go home and complete their ADLs. But when we try to think of what we can do to change this once this has already happened, then some people point their finger at maybe it's medications, maybe aspirin and Plavix, and those patients we can focus in on those and hopefully get better outcomes with those. And I understand how we arrived at this conclusion because 25% of patients who have hemorrhagic strokes are on these medications. And patients who are on these medications have a 27% increased odds of death compared to those who are not on these medications when they have a hemorrhagic stroke. So it's reasonable to think that, yeah, maybe we should help out these platelets that are altered with these medications by some new platelets. Let's give them a transfusion. And luckily, there are a couple of smart physicians over in Europe, in UK, Netherlands, and France, who designed an RCT back in 2016, multi-center, that took a look at this question. The question being, should we hold platelets or give platelets to patients with acute intracerebral hemorrhage. Does it improve their outcomes? And before we go further and talk about what they found, I want to talk about who they looked at. So they included patients who are on aspirin, they included patients who are on Plavix or both, and they included only atraumatic bleeds. But just as important as who they included was who they excluded. They excluded subdurals. They excluded epidurals. They excluded if the physician thought that this bleed was due to an aneurysm, so probably most subarachnoids. And they also excluded patients who had intraventricular extension of a bleed. And finally, if it was in your cards to go to the OR within 24 hours, you're excluded from the study as well. But it still leaves an important group to look at. In a group of atraumatic, intracerebral, intraparenchymal hemorrhage who were on these medications. Perhaps they could benefit. And what they found surprised, I think, even the authors, because they went back and forth to try to explain this in their discussion, why we found that the patients who received platelet transfusions did worse. They had worse survival, worse neurologic outcomes. But this isn't just the only example where we try to reason our way to a treatment to justify it, only to be proven wrong by the data. When we see that monitor show a gnarly, grim rhythm and chest compression start, it's only natural for us to want to reach for this and to secure the airway, to intubate the patient. Why not? We have to do everything that we can. And up until recently, I think this went without saying, but in 2017, yes, this is retrospective multi-center, but over 100,000 patients in this study. And what they looked at was for all these in-hospital cardiac arrests, who did better? People who were bagged for the first 15 minutes or people who were intubated for the first 15 minutes. And specifically what they looked at was survival, ROSC, and functional outcomes. And again, these findings were a bit surprising to the community. And I'm going to show the numbers. All these are statistically significant. I'm going to show the numbers for the patients that were intubated compared to those who were just bagged. So they had worse survival. They had less ROSC and worse functional outcome. Now, this is inpatient, but we also kind of see this in the pre-hospital data as well. In this study, when you compared the BVM rescue patients to the intubated patients, then we saw that the intubated patients actually had worse survival again and worse neurologically intact survival. Now we're stuck trying to reason our way back to figure out why this doesn't really make sense to us. And I'll give it to you that intubating protects against aspiration. And yeah, it's a secure way to ventilate a patient. But you can also have esophageal intubation that goes unnoticed, and basically you're not ventilating the patient if you don't do it right. Just as important, perhaps even more important, and we touched on this earlier with some of the talks with the advanced care of a coding patient, is it might distract from what's really important. What's the tried and true for cardiac arrest? Good compressions and electricity when they need it. Epinephrine is a debate in and of itself, but to the best of our knowledge, it improves survival to admission, but not to hospital discharge. But that's not something to be shrugged off, in my opinion. At least you give family a chance to say goodbye, and it can help with harvesting organs if that's the patient's wishes, or we think that that was their wishes. And something that I'm sure a lot of us have seen when we are in a cardiac arrest in a code is, out of courtesy, we stop compressions to let the person intubating pass the tube. And it's during that pause that invariably the brain is melting and the chances of this patient surviving evaporate. So maybe this blade is actually harming patients instead of helping them, which is what we thought initially. Now, bread and butter, something that attracted a lot of us to the field, trauma and bad trauma. And when we get the notification over the phone, that red phone rings, we rush in, we prepare, and sometimes in that preparation, fluids are hung. And sometimes the patient gets those fluids if they're in the really, really sick patients. Now, we've known since the 90s that this might actually be harming the patients. But despite this, it's remained as a relic for care. And I'm sure everybody can think of a time where fluids have been started on a hypertensive patient that came in after a serious traumatic injury. Recently, it's come more clear in focus the role of fluids in trauma. And what I mean by that is how detrimental fluids can be. So this is one study, 2011, retrospective, over 3,000 patients. And they split their group up for traumatic injuries into two, the non-elderly and the elderly. And what they looked at specifically was the odds ratio for mortality. And once you hit 1.5 liters, this was found to be an independent risk factor for death. And there wasn't much variability between that and going over 3 liters, although again, all statistically significant. But for the elderly, they couldn't tolerate it. And I feel bad even looking at these numbers to think that some patients got over 3 liters, and you can see the harm that we cause these patients. So I want to end with fluids because this calls into question the general role of fluids. And fluids is something that's almost ubiquitous. How many times have we gone through shift without ordering fluids? I think it's pretty common for us to reach for that clear bag with the hopes that maybe we're helping out. I mean, that's the common denominator here. But are we really helping our patients? Is this really helping a patient with a viral syndrome who's tolerating PO? Is this helping patients with nephrolithiasis? Is this helping patients with migraines? Ask Ben Friedman. Is it helping our patients or harming our patients with trauma? I think that we're starting to get a better idea of that. But one thing that I want all of us to scrutinize is the recommendation tied to incentive for giving 30 cc's per kg for septic shock and the indiscriminate adherence to this, especially in our older population. This should be tailored. We should not try to harm our patients. So with that, it's a very difficult job that we have. You know, we stand on the shoulders of giants, but we also have to question them. And the onus is on us to prove that our interventions are effective and safe, to question the roots of our practice, and to go back to that oath that we took at the very beginning of this journey to do no harm. Thank you.
Thank you for ending us, Dr. Gilberti. And that's a wrap, everyone. So from ALL NYC EM and from the Metropolitan Harlem Emergency Medicine Residency, I would like to thank you all. We would love to thank you all for joining. We had over 900 people attend, which is pretty outstanding. We had people from upstate New York, people from New Jersey, people from the New York City tri-state area. We're really happy to have all of you students, attendings, residents. So thank you for joining us. We hope you like this conference. Please make sure you registered and hope to see you at our next conference coming up in the spring. Thank you.